7 French guideline.
Yeah, I think, and that's a good strategy to, if you have proximal dissection, you can put the guide extension beyond it and then go through it. But the problem with ROTA is that it's not really compatible unless you have a much bigger guide.
Right. So it did mean then it was changing. So we just went through steps by step. I think in the interest of time, we should move on. If there are no other suggestions, but I think that, yeah, I think the final suggestion of Ajay was right, that we should look at larger burrs in such situations. But I mean, for the first time, I had this situation of IVL not cracking a focal calcified lesion after 80 pulses.
Add a compliment to what you just did, because you know, basically your methodical thinking through is it was actually illustrative, and now I'll show you what I call a bad day at the office. I generally tend to think I'm reasonably good at interventional cardiology, but this is one of those days where I wasn't thinking right. I was doing things in a way that I probably wouldn't normally do them, and I'll show you how I had to essentially persevere to overcome. So this will be instructive in many ways. Basically, this is a gentleman who has an EF of 30%, newly down, also has some other medical problems, and had a stent placed in his right coronary artery several years ago. This is what the right coronary artery looks like, and you can appreciate in that mid segment there's what looks like an underexpanded stent. There's also some disease a little bit distally beyond that as well. And on the left system, he has severe calcification, heavy calcification of the LAD system that's most pronounced right after the diagonal branch. So this is not a super tough case. This is kind of a run-of-the-mill calcified artery case with an underexpanded stent in the right coronary artery. So actually, because the EF was newly down and he had some heart failure symptoms, did a right heart cath at the beginning, and surprised that the pulmonary artery pressures were elevated. His wedge was up a little bit. And this was after there was an interval between the diagnostic and the intervention where he had some diuresis. So at this point, we were obligated, we were going to go ahead and do the diuresed him some more, but he had been anxious to come. There was a snowstorm in between, et cetera. So we decided to do the case. And, you know, ordinarily for that type of anatomy, and I can bet that in India, with that type of anatomy, you know, almost nobody would be using hemodynamic support. In fact, I would say normally I wouldn't either. But the EF was 30. The fellow, you know, in the case sort of said, you know, maybe we should use support. The EF's down. This is an underexpanded stent. So we ended up putting in hemodynamic support, which actually turned out to be a good thing because it allowed us to overcome my own bad day at the office to do the case. So what I would say is that if you're really good and facile, you wouldn't need it. And if you're not, then sometimes that's why it's helpful. And that doesn't mean that you should use it. It means that you should be not having a bad day at the office and should be doing a little bit better. So anyway, this is what we ended up doing, tackling the right first, and standard 6 French system, you know, radial, actually single access via the Impella, and, you know, tried pre-dilating. And the balloon seemed to be expanding in a reasonable fashion. And I did intravascular ultrasound imaging after that. I actually don't have that first picture, but basically showed that we had cracked the distal lesion and the proximal lesion. You know, I sometimes find this to be potentially helpful to sort of make sure that there's no waste there. And there is actually a hint of a waste, but the balloon seems to have gone up. And by IVUS, the area seemed to be reasonable, although, you know, the problem is there's a prior underexpanded stent there. So the big mistake number one was not understanding that this vessel is a much bigger vessel. And though this appears to be expanded, there still is actually a waste, given that the vessel is a 4-5. So it was actually challenging to get these NC balloons down, but nonetheless, with the guide extension, no problem. Put a stent in distally, put a stent in proximally. It seems like it's expanding. Okay, fine. You know, we're almost ready to move on to the left. So here's the IVUS image, and I think I'll just move through quickly. Basically, the distal stent, the vessel is huge, and the distal stent seems to be adequately expanded. But now I'm going to move to the proximal stent, which looks okay there, and now we have this area of underexpansion, which is, by the way, in an old stent. So while I go out there and give lectures about, you know, in-stent restenosis and you need to expand and all this stuff, I did the exact same thing that I lecture against. So now the fun begins, because basically you have to start trying to dilate this, and you have a new fresh stent in, and there's an old stent there as well. So take a 4O balloon, 15 atmospheres. I'm not showing the inflation pressures because they were at 30 atmospheres, which is not something you're supposed to do. We go back and image again, and while the areas are 5-ish or 4-ish and stuff, you still see there's focal underexpansion of that proximal stent. And with further inflations, newer balloons, this is what the result looks like, where clearly you have underexpansion of that double layer stent at that point. So now the question is, what do you do? And you can burr it out, you can take laser with contrast, you can go higher. And one of the things that we tried to do in this case was basically use a Laplace's law to our advantage and take a shorter balloon so as to basically expand it. And fortunately, with a 4O by 8, this actually cracked, expanded, and here you can see a better expansion. Then we ballooned it further, and finally the IVUS. I'll show you the what basically happened. This is that same segment, and you can see that it basically cracked and opened. But this was a lot of pain, it was a lot of suffering, and it was due to my own stupidity. Whereas in the beginning, I should have just made sure that I had a better result. And here's what the right coronary artery looked like that. Now, this had been somewhat of a struggle. I fast forwarded through the amount of struggle, but now we have hemodynamic support in, because we were going to do atherectomy of the other side. And ordinarily I would have stopped at this point, but because the support was in, we said, okay, we'll continue. So here we go again. And again, I'm still having a bad day at the office. I can tell you personally, there was a lot of stuff going on that I won't talk about, but it was also 2 days before the Capitol riots, which I, to the weekend before, had predicted to my wife was going to actually happen. And so you think I was scrolling the internet too late, and I just wasn't really thinking. But this time I said, I'm not going to do this again. We're just going to atherectomize. There's no prior stent, and it'll be fine. So go in, straight up atherectomy up front, atherectomize the LAD, NC balloons after. Now, I'll point out one area to you here. There's this area just before the tight area of the lesion, which by IVUS actually had an area of about 5 at the time. And so I elected not to treat it, just going to treat distal to that point. Again, that's not a smart move, because that's right in the inflow to your stent. So basically, after ballooning, stenting distally, we stent. I'm not going to show you the full stent. The stent looks fine. But what I am going to show you is the proximal area, because that becomes a major issue in a second, where essentially it looks like there's a little bit of a flap right there, but the areas are all basically preserved. So it's okay. I think if we don't have IVL here in the US outside of peripheral, but if you wanted to do that, that would be great at that point. Things looked fine by IVUS. Akiko was actually in the room. We were happy. There is this area proximally which we didn't treat, but that's fine. We're going to be all right. Except then when we take the contralateral view, you see there's a nice dissection there angiographically. And remember, this is a patient with an EF of 30. We have fresh stents on the right, now fresh stent in the LAD, and there's a dissection there. So some people actually would say, leave it alone. The area is fine. I personally, if you have an angiographic dissection at the inflow to your stent, you absolutely cannot leave that alone. So now we're back in again. And of course, we're back in with the same thing we had on the right, which is a big lumen, but a waste. Perfect case for IVL. As I said, we don't have it. So here we go with NC balloons, 4O by 8, take Wolverines, and after the Wolverine, which expanded a little bit, we have an MLA of 5.5. And again, it's a bad day at the office. So I said, okay, well, 5.5 is going to be acceptable if I put a stent in. I really just want to tack up the dissection and be done. So put the stent in. Here's a 4O by 20. Is it a good idea? At this point, I don't think it's a good idea, but I did it because I wanted to cover the dissection. And here you see with a 4.515, we go back to IVUS. I think the area is going to be 5.5 and it's going to be fine and I'll be done. But remember, we have to be perfect. We can't just be okay. And so when I say it's going to be fine, I push the IVUS in and now the IVUS gets stuck. So now what do you do? And again, this is after all this other struggle and pain and stuff. So now I actually started thinking, and this is where I started, I think, back to what is my normal baseline. So the IVUS is not going to advance. They're not going to come out. And what you don't want to do is you don't want to pull so hard that the IVUS shaft elongates and stretches and then potentially breaks. Similarly, you don't want to pull so hard that things start unraveling. So I stopped pulling, and I didn't want the guide to get shoved in to really compress the stent, because you can already appreciate there's a little longitudinal compression of the stent here. So that's when, as I said, I started thinking. So I cut the IVUS shaft, get a guide extension down, the IVUS still won't come across. The other thing you can do is advance the IVUS within the sheath to try to get more traction. I tried that. That didn't work. The IVUS actually moves forward. It just doesn't come back past this segment because there's under expansion and a bend. So because that didn't work, I was able to get another wire alongside it to see if I could balloon and free it up. So this is a wire alongside it. The problem is this is a 6 French guide and a 5 French BSC IVUS system. So even a 1.0 balloon will not get alongside this, and it won't simply work. So at this point, what do? Well, you have to free it up somehow. So contralateral access is obtained. And with a careful wiring technique, obviously not pushing too hard, not trying to compress the stent any further, get a wire to get into that area, then basically a wire to cross, and then a microcatheter to cross to be sure that I'm actually within the lumen, because if I'm behind stent struts and I balloon it, then the IVUS is going to be trapped for good. We got a microcatheter down, exchange for a wiggle wire, and then after ballooning more proximally, and I'm just going to move through this case quickly at this point, basically put in a guide extension catheter, got it close, didn't push too hard, and then removed the IVUS that was stuck. So now the IVUS is out, and now, again, because of the adrenaline, I'm thinking straight again, and so now we're just going to do the case. And basically, sequential balloon inflations, ultimately, even if 4.0 by 15 quantum didn't expand, it expands okay, but you can still see the waist here. And so took that same strategy as before, 4.5 by 8 balloon, which then cracked this, and then ultimately allowed us to complete the case. So that's what the final result is here. I did not repeat the IVUS to confirm my results. This is basically what I had, and somehow got out of this case. So what would I have done differently? I think number one is you just can't take anything for granted. You have to go be systematic. You have to think through things. I totally misinterpreted the imaging of the right coronary artery. In a sense, I think I almost forgot there was a prior stent there. I thought it was just a standard calcified lesion, and then opted to stent and ended up in trouble there. I would have probably done better had I had 7 French access in the LAD, because I had the Impella in anyway, and I could have, basically freed up the IVUS with a single guide technique. I absolutely would have atherectomized and treated that proximal lesion more efficiently, rather than just sort of say, I'm going to treat the distal stuff. And then I would have been more careful with the IVUS insertion and withdrawal, so it wouldn't have gotten stuck. The final conclusion is that I think the types of cases that we do with CHIP PCI, we can't get complacent. Every single one of them, we have to have focus. We have to think, because the margin is much, much less. Luckily, I was able to get out of this, but honestly, that took luck. It wasn't, and we don't want to leave our hands with luck. We actually want skill to be able to get us through these cases. So I thought I would show this case just because it shows, me at my worst, I think. But that's the only way we get better. So thanks so much.
Yeah, that great case. I mean, that it happens to all of us. And you're right, it's just a bad day, or it's just a bad situation. But, it happens to all of us, and we sometimes taken by surprise as to most unexpected issues happen. Any comments from the discussants? And we have others. Like I said, Kirti, feel free to talk. All of you. Yeah. Sitting there, Sanjog, Duan, Shiba, I can see a number of others. Maybe Nishit is there. Nishit, I don't see you, but that's the problem. When we don't see you, we don't know whether you're there or it's your camera. But please go ahead, Kirti.
So, Ajay, great case. There was a similar case in Pune actually a few days ago, where a good friend, Sirish Sate, got into this, and we got on a video cam, and we did exactly what you did actually, cut the shaft of the IVUS catheter and advanced a Guidezilla along it. And as soon as the Guidezilla went to the distal end of the stent, it released the stent from the IVUS catheter from the struts, and everything just came out. But you attempted that, and that didn't happen. So what do you think happened? Was the wire under a strut, or was the distal part of the wire under a strut where it trapped the IVUS catheter? Or what do you think happened? Why was it so bad?
I think the challenge is because the IVUS is such a short monorail. I think many of you remember the FX mini rail catheter that was around. These super short monorails, right, especially when you go down a bend and around, with a compressed stent with longitudinal compression, it essentially was, that bend just kept getting hooked on something. Because I could advance the IVUS catheter forward, it just wouldn't come back out through that area. So the only way to fix that is to then potentially expand that type of area.
So here's another thought, Ajay. What about if you really, I mean, one of those situations, if it arises again, would a snare down the IVUS catheter right to where it is, tighten the snare, push it, pull it, then you're actually working at the point of where it's stuck.
Yeah, I think
2 millimeter snare is what I'm talking about.
Yeah, so threading the snare over the IVUS catheter,
correct,
grabbing it at that point, and then
and
pulling it
and pulling it. It
would work.
It could work.
The challenge is that the snare catheter, basically a 1.0 balloon, would not fit next to the 5 French IVUS. So that I can't get a snare catheter down. You could get the loop of the snare with just a wire, but nothing further. And so that's the challenge with a smaller guide type of system, which necessitated the contralateral guide.
Right.
Ajay, I commend you on showing a case, and I just want to highlight that it's easy to get complacent when you're an experienced operator like yourself, because you've gotten yourself out of so many issues. So it's like, yeah, another case, I'll do like IVUS, and if it's calcified, then you kind of you woke up because at the IVUS separation, because that that's money time, that there's no recovery from that if you make a couple of missteps. And I think that last issue that you brought up, of don't get complacent and realize that, yeah, I'll just get myself out of it, or intellectually lazy, is something that's a danger for us. And I think that really is, apart from all the technical things you did, that's a wonderful lesson. I will dispute, though, that you were at your worst, because I've seen you worse than that.
So Dwayne trained me. Yeah, Dwayne trained me. But I will say, though, I can tell you that like skilled operators oftentimes can get out of situations simply because of their skill. But that doesn't mean that's a good way to practice, because at some point that's going to bite you. In this case, it very almost nearly did. So that's why I think, after the case, I sort of sat back and said, man, that was really dumb. Some of the things that I did during the case. But I think it's important to show it, because typically at CHIP meetings, people show their kind of best work, and there's a whole other side to it. I remember vividly, just really quickly, at another CHIP meeting, an operator came up to me and said, I hear your talks, and we tried doing a lot of this stuff, and actually had some very, very bad outcomes after doing it, because we didn't do it with hemodynamic support, or we didn't do this, that, and the other. And I said, yeah, that's the problem with CHIP meetings, is that there's a lot of learning and work that goes into showing the cases that get shown at these meetings. So that's why I thought it was a good thing to present.
Great. Let's go on to Sanjog now. So Sanjog, over to you. Yeah.
My worst. Hopefully this doesn't seem like too much of an example. So I entitled this case, I'm sorry, that's really not what that's supposed to look like. So this is a 68-year-old guy who had a non-ischemic cardiomyopathy with the usual interventions prior, who then ended up needing a surgical LVAD placement, and post-operatively developed hypotension and post-LVAD RV failure, and was referred for Impella RP insertion. So the Impella RP is a large 23 French device. It goes in using the following procedure. You get bifemoral access in both femoral veins. There's a PA catheter that's put up from usually the left groin into the right PA. Then using a balloon wedge catheter, you put up the wire that comes with it, which is typically an 021 Platinum Plus wire. And that goes through the balloon wedge catheter into the left branch PA, so that you have this little X at roughly the level of the pulmonary valve. Then along that wire, this is the old generation of the device, you would advance this device, and then as you hit the RVOT, you have to kind of pull back on the wire as you do a clocking motion to be able to come around the RVOT and let it pop upwards into the PA, where then you can get an inflow here at the low RA, and then an outflow here into the PA. So it's an RVPA bypass catheter. The thing is not all RVs are created the same. Sometimes angulations are funny, particularly when they've been manipulated in the setting of a recent LVAD surgery, and and or lots of remodeling, and sometimes the wires get stressed. And so in this case, the wire was stressed, and they ended up actually having to go to a V18 wire, which is a supported wire, but is not exactly the wire that comes with the kit. So the patient thankfully recovered well on the device. Everything went just fine. And by day 5, he was off inotropes and RV support. And so we went to pull the device. And that's what came out. Now, all of you, I'm sure, have seen what Impellas look like. The Impella RP, which looks like this, looked like this when it came out of the groin. And so this, I remember being in this situation. This was back in New York, and I remember calling Ajay at the time going, listen, there's something missing here. This is not what this is supposed to look like. So,
I remember your voice.
Yeah. This is not what this is supposed to look like. I've done enough of these now. And so that's what was going through my mind. So I thought to myself, where is this thing? So I found, so we brought him urgently to the cath lab, and that's what we saw in the abdomen. A fragment of the Impella RP where the drive unit had actually detached from the entire catheter, located just inside the iliac vein, partway into the common femoral vein, but in the retroperitoneum. So I remember Koji came down and the surgeons looked at it, and we did a lateral shot to see where exactly it was. And it was pretty deep in the retroperitoneum. So they said, listen, this is not a good idea. You guys should take this out. And so that's when, the team went into beast mode, so to speak. So what's the large retrieval device algorithm thing? I looked this up to see if there was actually an algorithm that was nicely published from interventional radiology or our vascular surgical colleagues, and surprisingly there isn't, great stuff. So just as Dr. Said said a few minutes ago, you sort of have to rest on experience. Just in the interest of time, I'll move through, but it's sort of something that I'm sure the panel is mulling around. So these are the things that we thought about: a snare device, maybe a local cut down, maybe go in with a bioptome, which sounds crazy, but I actually did that with a closure device the other day, and it works fine. Just don't get any tissue with it. And then there are a bunch of other things that we kicked around. So ultimately, we used a 24 French dry seal that went into one of the femoral veins and was put up too close to the device, but we took great care not to hit the device because we didn't want to accordion the front or injure the front part or the fragment so that we couldn't pull it back into the sheath. And then we tried the normal stuff. We tried a snare. There was a gooseneck snare, desperately trying to get around this thing, but it was the angulation that really made it quite difficult to be able to do that. And then even when we did, this is a soft segment of the catheter, but it's not easily compressed. So it becomes a little bit more difficult to pull it into the sheath with just a snare. It won't fold on itself very well. So recognizing that didn't work, we thought to ourselves, okay, let's try something else. And so what
Sanjog is recognizing that the outflow cage is metallic, and there is one bigger sheath you can use, and that's the micro sheath used by the electrophysiologist for the pacemaker implantation. Is you put that in and take an 8 French Ansel sheath with a curve on it and snare the pigtail and pull it around the other side.
Go jugular.
Interesting.
Go jugular.
And pull it out through the jugular vein. That's also a good thought. Right.
Yeah,
Grab one on either side.
Snare it on the metal, distal to the metal part. The metal part will prevent the snare from coming off, and you just deliver and use a mother-daughter with an Ansel.
So what for the audience, who hasn't seen an RP, what Dr. Pinto is referring to is this segment here is metal. And so you're thinking, and it gets a little bit bigger than the pigtail. So he's thinking the snare won't necessarily come off. So you can sort of do a mother-daughter with an Ansel by grabbing here at the top, which is an interesting thought. Let's just see. Maybe that's what I might have done. So the supercore wire was inserted actually through the device. And initially what we wanted to do was get control within the device. And so an Admiral 70x40 balloon was advanced actually into the device along the supercore wire, which was actually used to go from the inside of the fragment right through the end.
Actually, Sanjog, can I just interrupt to tell a very funny story at this point?
So, I know the story you're going to tell.
So the wire, we're trying to struggle. We can't figure out what to do, and the wire somehow goes through this device, and we see the wire go through. And so Dimitri and I were together, and we look at each other, and we were like, just really happy that we have a wire through the device, because it means we have some control of it. And the first year fellow, who at the time was there, who actually is now a very successful chip operator, and it's not Sanjog, went to the head of the bed and said to the patient, "Sir, we're almost done. We got the wire through." At which point, Dimitri and I basically told him he's not allowed to talk for the rest of the case. So that's this funny story.
So we had this individual finds themselves on podiums a lot. He's a great operator and a very, very close friend. And we literally talked about that story yesterday as I was planning on presenting this. So put the balloon inside the fragment, tried to pull it back, and the problem is the balloon kept slipping out, right? So we couldn't get this thing back. And as you'll see, as we try to very gently and carefully and slowly pull this thing back into the dry seal, the end of the fragment hits the end of the dry seal and the balloon actually slips out. We tried this actually a couple of times with increasing pressures as we were pulling back, because we saw it pulling back, and unfortunately that didn't work. So now what? Well, you still have control of the device. So let's see if we can re-advance the balloon into the device.
Angiovac suction.
Oh, that's an interesting thought. I hadn't thought of that. So unfortunately, during this balloon advancement business, the wire came back and the device went right back up into the RA. So at this point, we're a little bit less happy, because this is obviously something where if you start getting caught in the tricuspid valve and what have you, it becomes much more difficult to get a hold of the end of that pigtail, which is the challenge. And so at this point, I just was like, get out of my way. So he stuck the balloon and pulled this back into the iliac vein. And then what? So now this is a 24 French dry seal. So you're able to get something next to this whole set. So this was the point where a two-pronged attack, sort of a boot and suspenders attack was considered, where we then put up a guide catheter next to the device, took that big snare, and just as Dr. Pinto had suggested, grabbed that pigtail and pulled it downwards. And so you'll see that there's capture there right at the very end. So now you've got a wire through this big fragment and then a snare on top of it. And so that's sort of a two-weight approach. And then we pulled the entire sheath snared pigtail device thing right out of the groin and put pressure, which actually was really easy to seal with just manual pressure. I was shocked by how little difficulty it was associated with that.
Left femoral vein would have been 5 minutes job.
Well, that's an interesting thought. I mean, I think the pigtail was kind of soft because it had been inside the body for a while. So pulling it from the top of the pigtail and out through the left femoral vein, I worry that pigtail would have stretched, but certainly something that can be tried. So this is what it looked like at the end, where we sort of had a wire through it, a balloon inside it, and then a catheter along it with a snare at the very top. This was the issue. The glue near the motor housing had broken. So lessons I learned were: don't panic. Have a plan A, then a plan B, and a plan C. And if you have a minute to think, then take it. And recognize that the kit is the kit for a reason. And when these devices are under stress, they're not impervious to breakage. Thank you.
It's amazing. Great case.
Very, very nice case.
Awesome.
So Sanju, what about, did you consider it jugular, pulling it up, getting it out from the top?
I think that's a good thought. I think our big concern with that, again,
we haven't seen RP, but from what Duane said, and you know it, perhaps that upper end is bigger, and therefore a snare could have actually not slipped off. Do I think of it correctly? Is that what you?
I guess what you would have to do is slip the snare past the pigtail, past the larger metal segment, and then snare the middle of the fragment and pull back. The challenge with that is, if you're coming from the IJ, is that you have to drag this thing through the heart. And that would make me very uncomfortable, because not only is the device flexible in the mid segment, so where you've snared, and as you pull back, what other structures it hits, you can't predict, right? The other piece is actually getting the snare all the way from the IJ down around the thicker part, the metal part of the device. Now, if you are able to snare right underneath that metal cage and compress, you'll get a good hold on it. But your snare is going to come at it at an angle. And so then when you come back up to the IJ to try to pull it out again, your pigtail, which by the way is now soft, so it's not a good thing to snare on unless you have some sort of a backup, is going to bend. Bending them through the IVCRA junction or the SVCRA junction and then into a sheath, I think is a less predictable enterprise than taking it out through the leg using an inner and an outer approach.
Okay. No,
The main question, the main thing about the going through the heart part is I think you could see in one of the two of the images is how much hardware the patient had with pacer leads and all kinds of stuff there. And we were just, every time it went up near the heart, we were just like afraid that something
gotta get
catch something else.
No. You have to go. Your microsheath, though, your microsheath will reach up to the groin from the top. And what you have to do, you have to slash the dead end of the microsheath, and it will become a oblong thing. It's not a round thing anymore. So you can just pull it through the large device, large ASD, large VSD. You can pull it out.
Yeah, PK, that's a good thought. You know, I know you do a lot of EP, and so you're obviously very familiar with some of these things. Ajay, I don't know. I've nenever played with that sheath. I do even have it.
The electrophysiologists don't know anything about the large bore sheath either. They just do it every once in a while. But
I'm a student of said.
That's the next session.
Well, what I'll say is I like this
That's an
idea
interesting thought.
of the mother-daughter, but I personally like it from the other iliac for the reasons that Ajay said. But not the least of which are the very tiny practical issues. Is you've already closed the right groin with a figure of 8 or something like that, so you don't have to mess with it. You can prepare with a figure of 8 before your micro sheath is in. Cross over, snare it, pull it out, close it, go home, and have coffee.
Well, it was shocking.
I think we're going to move on. Great discussion.
The wire was a super.
I know it's going to carry on. We 7 minutes behind time, so I'm sorry. We just have to move to Kirti's talk.
Hi. Awesome cases. I mean, my case looks like a very simple thing. I'm good at that, isn't it? So this, I want to call it the between the devil and the deep sea, because it's like my question was, what do I do with this hard rock, and do I kind of risk a perforation? 57-year-old ACS raised troponins, critical calcified tortuous mid RCA, and an eccentric, very hard LAD lesion as well, as you can see. The focus of this talk is this right coronary artery. And I thought it was, though it was calcified, tortuous, large, I thought it would be a fairly simple case, but not until I started that every step was a struggle. You can see that it's got a couple of right angle bends, and when I look at once the wire was in, it almost looked like a spiral going down that RCA in the mid segment, and heavily calcified as well. So the questions, these were the questions I had. I wasn't sure what technology, what kind of lesion preparation I was going to use, but I did think that using, I thought just a balloon should do the job. If I could get a balloon across and then trap and get a Guidezilla across and then put in an IVL and crack it, that should be it. But then let's see how this case unfolds. First of all, even getting a wire across this artery was a big struggle. And once I got the wire across, I somehow managed to get a 2.5 millimeter balloon, 12 millimeter balloon across, and gradually went up to around 18 atmospheres. And the balloon just would not go beyond this one spot that is seen in the center image. And when I pulled it back, every time I pulled it back, if I had to advance it, I then needed a Guidezilla support. So, and with that Guidezilla support, I still backed out my guide catheter, which would go into the aortic valve and cause severe AR and destabilize this patient. So I thought maybe I needed to expand the proximal part of that RCA, before the bend part of the RCA a little to a larger size. So I got in a flexdome, and I was able to manage the flexdome getting right up to that bend, and went up to around gradually up to 18 atmospheres with that. But beyond that point, it wouldn't take that bend. The question was, after having tried multiple balloons, and now we're already like an hour into this case, I thought my options were just rotor-blader. So we took in a 1.5 rotor-blader, and this was, we started with 190,000 revolutions and went up to 200,000 revolutions. These two runs are just the example. These are just to show you that we were making a little bit of purchase in that lesion, but this was almost more than 300 seconds now, more than 5 minutes of rotor time at a 200,000. So what I did here was I changed the burr to a new 1.5 burr. And once I took that new 1.5 burr, I realized that it was making a little more purchase, a little more rapidly at 210,000 this time. And I was able to go across that lesion slowly. I thought it should be easy after this point. So we'd had 450 seconds of rotor time, multiple in aliquots of around 20 or 15 seconds. And we had used two burrs of 1.5 millimeters. Now, one may ask why, because what happens is, and this is interesting, the burr on the bottom part is a new burr, and the top is a used burr after 300 seconds of burring. And you can see that the shiny brass-looking metal at the tip evaginates out. And when it evaginates, it obscures the leading edge of the boring to kind of hit the lesion. And that is one of the reasons why, beyond a certain point, the burrs do not advance at all, and they do not do their job. And so it's just, and this image was, these burrs were imaged by a friend, Dr. Viraj from Thailand, by using his macro lenses, and that's how we learned about it. So then once the burr was done, we took a 3.5 millimeter balloon, and it went into the lesion, of course, with the Guidezilla support at 16, 18 atmospheres. Brought it back right at that bend, 18, 20 atmospheres, and it just did not yield. Was time to use a IVL balloon like we pushed in there, as you can see. And what happened, 60 pulses later, the IVL gave way, but this is what happened. You can see the tram track RCA there, and my wires and my equipment have moved away from the original right coronary artery wall. So I have created a neolumen that appears to be outside the original vessel wall. And this is what it looked. This is what the angio looked like. The question is, oh my God, what do I do now? My previous experiences with this was in the proximal left mains and circumflexes and very proximal bends and in a shepherd crook right, where we've taken very low pressure balloons and put in stents at low pressure and gotten away with those. But we weren't sure of what we were doing at that time. And the question that came to my mind here is, I either risk a massive perforation or I just abandon the case at this stage and just distally dilate with a little larger balloon in that straight part of the RCA and leave it on medical management beyond. So we put in an IVUS catheter to see what's going on. And this is the IVUS catheter. Just for everybody's sake here, this is a large artery. This is an HD IVUS catheter, and you can see the dark media all around. You can see my central catheter there and my wire. And as I pull it back, you can see that the catheter remains within that black shadow of the media throughout. You can see the neolumen at the side, which comes and emerges. It's a very eccentrically placed and a skewed space. This is the neolumen that we created and has slipped into that groove. And for a very brief moment, you do see tissue between that lumen and the actual lumen. And here are the images that I share, the cross-sectional images if the movie went on too fast. But and that's the last one. You can see that the neolumen is this blue color lumen here. and there's tissue right up there, but there's a continuation. But what angiographically looks disconnected, and this is the actual right coronary artery. The sizes were around 4.5 millimeters distally and around 5 millimeters approximately the luminal diameters. So what I did was I took in a 4 by 22 millimeter stent distally, went up to around 12 atmospheres, and then dilated the proximal 5-6 millimeters of the stent with a 4.5 balloon and advanced a 4.5 millimeter by 18 and anchored it into the proximal part of the stent, of the artery. We went up and optimized the same with a 5 millimeter balloon, approximately 4.5 distally. And this was the final result that we saw. We saw these two parallel lumens that happened. This was the IVUS image. And it was interesting that the stent segment still remains within the vessel architecture, which is interesting. And this was only 3 hours late, 3.5 hours into the procedure that we had this result. 220 ml of contrast, almost approaching 5 grays of AK, and 90 minutes of fluoro time. I thought, of course, we all know these algorithms, and this is what I follow. We try to do a CT calcium map to know which way and how much calcium's there, and kind of have before we go into the cath lab, kind of a strategy of what devices we may need for the day. But if the imaging catheter cannot cross, then the question is a rotor wire, and if the rotor wire crosses 1.5 a rotablator does the job. We have to work a lot even beyond that. But if it doesn't, then I do use the tornus frequently to see if I can make some room. And now we have the ELCA. We don't have orbital atherectomy, so that's still just vertically. But beyond that, we put in an IVUS imaging. We define lesions. But important is the bias, the wire bias of the calcium. If the wire is biased to the calcified area, I still prefer the upscaling the burr, because that is the cheapest and probably a technology that I've used for the longest time and safest. Eccentricity is an issue which I look at, because that helps me undersize stents when there's calcium on one end and a free wall on the other, and an artery heavily calcified, eccentric plaque. I need to undersize the stents. And fractured calcium, of course. These are all complex things, but basically the wire bias lets you go to an escalation of burr strategy, whereas all the other strategies lead to an IVL shockwave lithotripsy in my lab at the moment. My learnings from this case were severely calcified lesions with tortuosity, difficult lesion subset. You need a complete toolkit and a skill set. Angled calcified lesions, neolumens are not uncommon with the use of high-speed rotational atherectomy, especially when used with adjunctive devices which are going to crack calcium, and there's slippage of the wire into the lesser curve of those plaques. Imaging helps neolumens if they're well within the vessel architecture, which can be studied quite easily using intravascular ultrasound. It is safe to implant DS, not at low pressures, but using standard practices like I did in this case. Thank you, and I'll be happy to take some questions.
Showed how imaging had given you more insights into what you were doing. Yes, those neolumens have been created by all of us doing a rotational atherectomy on tortuous and angulated bends and curves, and more often around the left main circumflex osteas, which are usually right-angled. But this was another right-angled bend that you actually took, and then you imaged it and got out of it very neatly. I guess this was done recently. We don't have any longer-term follow-up on this, do we?
So this was done approximately 2.5 months ago. So right. Maybe by the next
gypsy, this is what we expect from you.
Yeah, of course.
Any questions? We are 5 minutes behind time, but we can actually take a couple of questions because we're still doing pretty well on time.
And Kirti, that was an amazing case. That was a rotofloppy wire that you used?
Always use a rotofloppy. I've given up use of the rotor extra support because it's so dangerous on these bends. Actually, it made our arteries look much worse and deviated the wire away from the true lumen a lot more than the floppy does. Yeah.
Yeah, I was going to say, because sometimes people, if the rota doesn't cross, they then upsize to the XS. But in this case, especially, man, that would have been, this was a one cell layer away from an enormous perforation. Actually, when you saw the disarticulated vessel, that's what I thought you were going to see. When you said show the angio, it's better than I expected.
So
I haven't ever heard of an experienced atherectomy operator using the Rota XS wire. So, I mean, I wonder if they should just discontinue making it, you know, because I see more of the like complications are preceded by, you know, I switched to an XS wire.
Yeah, I personally think the Japanese use a fair amount, a reasonable amount. I won't say a fair amount. That's, I think, where the most of the rotor extra support do get used as an alternative, but nowhere else.
So Ashok, I think that the one place that I would use it is in an ostial right coronary artery where the guiding catheter comes and abuts into the lesion and then ventricularizes pressure, because when that happens, that is a recipe for a stuck burr. So what I do is I face the guiding catheter, I pull it up a little bit superiorly to the ostium, face the guide catheter in the opposite direction and let my wire loop in the aorta, and then run the rotablator burr in the aorta across, and my guide catheter and my coronaries are both looking the same direction. And it works brilliantly. And there the extra support wire works well.
But even rotofloppy works well, because once you're aligned and once you can get your guide close or far, but as long as your alignment is correct, your rotor burr will actually go that.
Kirti sir, what would be the cases though where we would not be able to stent the new lumen? And then what would be our strategy in those cases?
If you think that you see what happens to the vessel architecture is defined by the internal and the external elastic lamina. And when the internal and the external elastic lamina are together and the media is sandwiched in between, that means you preserved your vessel architecture. Often enough, what you see is that part of the media is on one end, part is the other, and you're in the mural space that is in the medial space.
Right.
But once you get into the mural space, and if you can see that on the IVUS, that you've divided yourself, the internal elastic lamina on one end, external on the other, and your materials are in between, then you're not sure how much leeway you have. And there, I would not do much. I'd do very low pressure dilatations and probably get out. I wouldn't have put in a stent. Or the other thing is to just take a very long covered stent from the distal end of the artery and go and put covered stents as a first option rather than doing anything else, because you then will run the risk of extravasation to a large extent.
So would we be able to leave it alone on medical therapy after those low pressure dilatations?
Oh yeah.
Yeah. Sometimes you might, if this is what we did, I think Ashok would attest and everybody on this audience would attest that at times all we did was balloon dilate these areas and just prayed. And these arteries healed well over a period of time, and some occluded, and then you can come back because now there's fibrous tissue and you can work yourself and work it again. And I have a couple of cases like that as well. But
Absolutely.
Wonder what the others think, like. I mean,
So that's a great.
Kirti, one question. Why don't you take another wire and go into the other lumen and then again confirm on IVUS after you have done rotablation?
If you saw the IVUS images, if you saw the IVUS image as well, this is a angiographic illusion of two lumens. It's not two lumens. It is one lumen. It is a figure of 8. So every wire you take, the wire does not have the intelligence to remain in the true lumen. It will go in the path of least resistance and in the straightest course of the artery. So that's the problem.
Agree with that.
Basically, the burr just followed the wire bias. And
That's
luckily, in this case, the wire bias was actually where the calcium was, which is why it wasn't a perf. Whereas if it was on the opposite wall, the burr would have gone that same direction. And even though it's not supposed to cut normal tissue with that much straightening, it still will, and you would have ended up with a perf. So it's not like a true second lumen.
Correct. It can't be a true second lumen. Your wire is in the lumen. So it cannot be a true second lumen. It's only a false second lumen because that's the appearance. The burr is trapped the wire. The wire didn't go through a second lumen. So it's actually an illusion. And that's the safety. That's what you got to look at, the safety of it all. So low pressure stenting or low pressure drug-eluting balloon and come back. But whatever you see is an illusion rather than but you're just very close to the adventitia. That's all one says. Okay, I think we should move on, isn't it? 10 minutes late.
Really cool pictures either way.
But that is tremendous. Oh my gosh, learnings from there. These were tremendous. I think.
I love the proceeding that it wasn't, that interesting of a case, but I'll just tell you an anecdote. I never take notes in a lecture, but I take notes in your lectures. I have a list of like atherectomy pearls that from the atherectomy lectures that you've given in the past. So just a little anecdote.
Great.
I use your slides to teach my fellows how to make slides.
Are you referring to Ashok? You're referring to me?
Both of you. But I mean, your IVUS slides are the best slides I've ever seen.
Hey, thank you. But my mentor is sitting right there, Ashok. I've learned a lot from that man. And of course the rest of you who I discuss so many things with. And I think I'm so happy to be in the midst of all of you today. And
Keith is purposely making me feel older than I should. That's all.
No, you're not.
That's all right. You look younger than you should, so you're good.
Great.
Yeah.
Let's go on to the next one.
Hey,
and
thanks. Yeah.
Oh, you great, Keith. Wonderful. So this is on large bore access and closure, step by step. I think I've named it the big boys too, but really as we go more and more into structural intervention and of course mechanical circulatory support, all the new devices that we talk about, we really need to get masters at both access, safe access and closure. And with me are co-chairs Raj Dayal and Dr. Vijay Kumar, and we have discussants with Dr. Kathleen Kearney, Michael Leaf. He's come back from his acute primary PCI call that he was doing, Dr. Vivek Kumar, George Koshi, Nishit Chandra, and Shiba Chabra. Please stay on, and we move to Duane Pinto for femoral access fundamentals to advanced obese.
That's a really apropos summary. I'm going to try. I have a number of slides. I'm going to try to cruise through here. There's a lot to cover, but I wanted to start off here. Let's see if we can go forward. Okay, so we're going to go through. Here's the agenda: anatomy review, best practice for femoral access, and then techniques you should know: crossover angiography, pre-closure, single access, and then because it's a CTO meeting. I termed it in terms that the CTO operators can understand when you have complications in the periphery. So anterior wire escalation with various systems, retrograde wire and externalization, and then dissection perforation, thrombus management, calcium. And then, frankly, with Raj on the line, there's no better person to teach axillary. So I'm not going to go over that. And delayed closure, I'm not going to go over that either. There's not going to be enough time. But that's for maybe the fourth course. Because, frankly, the overall, teaching is understanding the fundamentals, as Dr. Seth said, is, first of all, I've been teaching this wrong for like 20 years. We don't actually compress on the femoral head. Now looking at a lot of CAT scans, and the relationship of the common femoral to the bony landmarks, we're compressing on the acetabulum. I don't know why that was, a strange concept to me, and why I said we're always compressing on the femoral head. But this is why I'll show you a picture. There's a difference between what we think is the common femoral with regard to its functional status as an access site and its anatomic status, which is sometimes poses a problem. I also want to review one of the landmarks on angiography, and that is the inferior epigastric artery. We used to say, as long as you're below the inferior epigastric artery, you're fine. You're not in the retroperitoneum. But indeed, some people's artery has a very deep loop, and the loop goes around the inguinal ligament. So you want to be below the inferior border of the inferior epigastric artery. And what this means is you know where you are before you put the big sheath in. So predicated on that is doing a small angiogram before. So we need to crawl before we can run. Don't talk to me about axillary access or ask Dr. Greenbaum about transcaval access until you can do the following: identify fluoroscopic landmarks, ultrasound guidance, micropuncture kit. If you're going to argue with me about that, then we can't have a conversation. It's like I'm not going to get into politics. So, and then you need to be comfortable with when you use a default femoral angiogram and when you decide to skip it. So this is the idea of a functional common femoral artery. So if you're looking on ultrasound and you see that now you're in the common femoral, you may not be in a compressible area. Your goal is to be closer to the acetabulum so that you can compress in this area or you can deal with it if there's a complication. You don't want to be below this, even though this could be the anatomic common femoral artery. So in other words, what follows from this as well is that you need to use fluoroscopic landmarks, and you need on ultrasound to be comfortable with seeing the acetabulum and the femoral head. I also think that making a smaller hole is than a bigger hole is a good idea. That's just pretty, common concept. And I think that in this case, you can see with this graph on the right-hand side that there's a substantial difference. And when Ajay mentioned he was my fellow, I started running out of things to teach him towards the end of his fellowship. So one of them is I showed him that you can cut the suture with the 18 gauge needle. Well, that also means you can cut a lot of other things inside the body with that needle. So again, I think that the micropuncture needle is correct. One of the concepts was to be discussed is dealing with obesity. And while you can see, the Pythagorean theorem in action here, a squared plus b squared equals c squared. When you're dealing with a very long track because somebody is obese, that angle of attack at approximately 45 degrees where we're to go in will be higher in somebody that is obese, and it's going to be lower in somebody who's thinner. And as a consequence, we have to alter our angle. But if we alter our angle, that means that the entrance angle of the sheath is going to be either shallower or more acute, which also puts tension on the arteriotomy, and we have to be mindful of this. So as I mentioned, I think that angiography, ultrasound, fluoroscopy are all very important together when it comes to access. And I think that when we look at these types of things, I think it's very important. Here's an example of an anatomic variant, a patient with a very high bifurcation, where the bifurcation is frankly in the pelvis. And by just using ultrasound and saying, I want to find the common femoral artery, in this case, the access was in the retroperitoneum, and the patient had a substantial complication as a consequence when the sheath was removed. So to go step by step, if you have a prior angiogram, review it. So it's very frequent that somebody comes to me and says, I think we need to do axillary access. The person has PAD. And I said, well, what does PAD mean to you? And we look, and then it turns out that the person has had an SFA intervention, and they've had angiography before, and that no one's reviewed it. And we can actually see that what the common femoral and the bifurcation looks like, et cetera. So I think, being rigorous about reviewing the prior imaging is important. Obviously, with TAVR, we review the CT angiography frequently, but I think it's a missed opportunity when someone has had prior peripheral angiography to not look. So I mentioned that it's obligatory for, I think, all interventional cardiologists who are interested in large bore access to know how to do crossover angiography. And bailout techniques all follow from this technique. So you obtain arterial access, use a crossover catheter, an OmniFlush catheter, an IMA catheter is what helps you navigate that bifurcation. Start off with a soft angle glide wire, which will allow you to deal with the iliac tortuosity. And then once you get to the common femoral artery, you advance the catheter, not unlike when you advance a catheter up the subclavian artery. You pin the wire, put a little back tension on, and pull it around. If you have trouble because there's a calcified bifurcation, or it's been stented, or very acute angle, you can use a 4 or 5 French glide catheter or slip catheter. If you have it, it's been a recall occasionally. Then once you've advanced that catheter, you can put a stiff wire down if you want to intervene to help deliver a sheath, or you can leave a very thin wire down as a safety wire. If there's problems when you remove your large bore, you can always work over that one. Or in the very least, you can see where the common femoral is and just stick the wire and know exactly where you are. Pre-close technique, as I mentioned, is also important to become familiar with percloses. And you put these in before. Here's a cadaver, and this happens to be an axillary artery. But this is what's occurring at the arteriotomy. I will also say that this is after removal of a 14 French sheath. So we're banking on some recoil of the artery. Some people have very elastic arteries. And even after removing a 14 French sheath in this very elastic artery, it's recoiled enough that a perclose and its foot plates that you can see through the artery have enough space to grab, the needles grab inside, and the suture is pulled through. So this is what we're hopefully seeing when we're pre-closing after inserting a 6 French sheath. At times, we can close bigger sheaths if this artery has recoiled, but that's for another day of post-close. And then this is closed in the standard fashion from the outside, but this is what's occurring on the inside. So in that way, you can deal with complications like this. This was an Impella patient. This was the access before. This is the lesion that we're dealing with. Fix the lesion. Everybody's giving each other high fives. We close at the percloses. We're giving each other more high fives because there's no bleeding. But that always distresses me, actually. When there's no bleeding at the groin, absolutely none, after the closure, I always worry that this has happened, that the percloses have, or I have picked up a posterior plaque and closed off the artery. There's one interesting phenomenon in interventional cardiology. When we cross a difficult lesion, we say the Gaia 2, I crossed the difficult lesion. But when we can't cross the lesion, we say the Gaia 2 didn't cross, so the device didn't cross. But in this case, I did it. The perclose didn't do it. So again, crossover technique, crossing with the wire, balloon inflated, sealing off that perforation there and restoring flow. And then in this case, I switched for 2 018 wires, and then in concert with a discussion with our vascular surgeons, put a covered stent in, and that was the bailout. So again, knowing the crossover technique, knowing your equipment, and then working together with your vascular surgeon. Here's a valvuloplasty complication, a 98-year-old woman. I don't know anything about mitral valvuloplasty because we don't see this in the United States, but I know about aortic valvuloplasty. But in this case, the sheath dissected, and you saw the flap there. The learning point here is you must go see the patient. Don't say you have to go through the stages of grieving. The first stage is denial. So yes, there's denial. That's not a problem. The pulses are fine. No, you have to go through that and see the patient. And then in this case, we crossed ballooned it, again, crossover technique. And then in that case, it was a durable result and the patient did fine. This patient had a TAVR placed, and after the closure, we noticed there was no bleeding. In this case, we were from the radial for the second access. And now that poses a problem because the crossover technique is either you get another access. The whole purpose of using the radial access was to reduce complications of a second access. So in this case, we have the Terumo R2P sheath, 119 centimeter sheath, and equipment with a 150 centimeter shaft balloon. We did the same thing as crossing over. We crossed from the radial, and this time now we put the wire into the descending aorta, crossed over. And in this case, I broke the perclosed sutures because frankly, that's the problem. The sutures have picked up the plaque and closed off the artery. So by breaking the sutures and manual compression, now there's a lumen to wire. We wired from the radial down the femoral and then did what you all would normally do, balloon tamponade, compression from the outside. And in the end, this is what the artery looked like after it was occluded before. Another patient here, left main intervention. In this case, she was somewhat decompensated with elevated filling pressures and had been turned down by the surgeons before. We encountered difficulty going up the iliac. You can see pushing on the Impella device, it wouldn't go. Performed some regular balloon angioplasty, tried with the large sheath, that wouldn't go. In this case, we used intravascular lithotripsy, has been shown in the coronaries earlier in the conference. Not complicated. You inflate the balloon and turn the thing on, and then we completed the case using a single access technique with Sanjog spoke about yesterday. And in the interest of time, I'm going to go through this. Here was the description that we had of this, and some rotational atherectomy was performed. I personally use the single access technique where we advance the catheter on Dynaglide. Here you see the loop getting bigger there with the brake in place, and then same thing on the way out. And this is the final result there. Again, this patient here had a complication of access, but I want to show one retrograde case. There was extreme tortuosity here. And so with advancing the wire, the iliac became dissected on the right. Using a series of wires, as you would in an antegrade wire escalation case in the coronary, attempting to wire the true lumen was not successful after about 10 or 15 minutes of trying. So rather than continue to struggle, we accessed the other side, which we were going to have to do anyways for the TAVR to put the pigtail up. So we crossed over, crossed into the from the true lumen, and not unlike a reverse cart technique, wired the sheath, flossed the patient, externalized the wire, reintroduced the sheath, and proceeded with the TAVR, which you can see on the right, all of those steps. TAVR went in. And as you know, retrograde dissections in the iliacs and femorals do pretty good. With antegrade flow, the flaps closed. So this was the picture afterwards, and we didn't end up doing anything. So again, this is what we covered today. There's more to cover, and it's all actually available for free, summarized on the SCAI website. Adir and myself edited a book where a number of the speakers in this conference contributed their expertise, including Kathy, who's on, and Adam and Raj. And so if you ever want to learn anything more, this is a comprehensive and free book. And so with that, I'll stop, and I'm sorry that I ran over.
So Raj, do you want to, okay, I've got a question and then I'll hand it over to Raj. So talk about the obese flabby abdomen and the femoral puncture. There are two aspects to it. You can either go through the flappy part and say, okay, I'm right, but that gives you a lot of subcutaneous tissue and really occasionally you run out of your perclose, or you lift the abdo up and therefore leave all that flap up and try to go through the shortest route. What's your normal practice and what do you suggest? And that's for a lot of people who are in the audience wanting to know about this.
Yeah, so I'm interested in everybody's strategies. I personally like to go in the shorter distance with somebody either retracting or taping up the pannus. And I prefer to try to keep it in something that I can visualize and compress. So I test it first manually, whether this is a site where I feel like I can get control afterwards if there's a problem. And then with that in place and the same traction, because if you feel around and pull the pannus up and then get access, you know, using your shoulder or elbow or something to keep things up, and then you change where you get the access, then that's where you run into problems while you're getting access. You create kind of a Z where you're going in and out and sideways and back and forth. And then when you put in your closure devices, they are hard to advance. So that's a long way of saying I prefer the shortest route, but it takes sometimes 2, maybe even 3 people to help you.
Raj, over to you.
Great, thank you so much, Dwayne. That was great. I think we'll move on in the interest of time and catch up. So it's my absolute pleasure to introduce the next 2 speakers who are the global pioneers in alternative access. The first of which is Jamie McCabe, who has done a tremendous amount of work both in the large bore as well as alternative space, particularly in the percutaneous axillary space. We've all learned a tremendous amount from him, as well as Adam Greenbaum, who has really pioneered techniques in transcable alternative access. So Jamie, over to you.
To be here this morning. It's 6 a.m. my time, so good morning. Hopefully you're seeing my screen. Just make this full screen here. All right, so the objective this morning for me is to talk a little bit about percutaneous transaxillary access and closure, which we will step through here. So first off, a little bit on the anatomy. The axillary artery is in continuity with the subclavian artery. The subclavian becomes the axillary as it traverses underneath the clavicle. The axillary tends to be described as having 3 sections. The first section is before pec minor, the second section is under pec minor, and the third section is distal to pec minor. And in general, these days, when we're talking about axillary access, we tend to talk about accessing somewhere between the distal first segment and the proximal second segment, and I'll show you why. But there are anatomic reasons for that. This is a cadaveric dissection. Dwayne stole my thunder here a little bit. I'll forgive Dr. Pinto for that eventually. But so in a dissection of the shoulder here, what you can see is in this segment, as we were discussing, you have a venous bifurcation here where proximal to where we're looking in the shoulder, the vein is overriding the artery. And so, in fact, if you look on ultrasound for an axillary access puncture site, and you are looking just distal to the clavicle, if you scan to medial with your ultrasound, you will note that the vein is right on top of the artery. And if you see that, you just simply need to shift the ultrasound beam a little more distal, and you'll find that there's a split in the vein, and that's where the artery kind of pops out between the two of them and is free from overriding vein. In the same area, this is the brachial plexus. It is a discrete bundle and not arborizing or web-like and not on top of the artery. So this sort of, maybe let's call it a few centimeter segment, 2 to 3 centimeter segment, in the distal first segment or proximal second segment is really where we want to focus our attention. And that's just labeling. All right, so in terms of axillary access, there are really four considerations that we need to address that may be slightly different or perhaps the same as femoral access or any other standard access you might be used to. The first is screening. And when it comes to screening, it is important, particularly as you start a program, to have some imaging up front. And that imaging can take multiple forms. Certainly for American TAVR programs, we are using a CAT scan in advance of the TAVR whenever possible. This may not be feasible regionally depending on resources, but in the context of having a CAT scan available, it's a great idea to get one, particularly as you're starting. And I think the one thing that CAT scan provides that other modalities might not is some relational information regarding how the artery ultimately relates to the aorta in terms of angulation for wherever you're going, whether that's to get down into the descending aorta to get a balloon pump in, or to get to the ascending aorta with a catheter or an Impella or a TAVR, whatever suits your fancy. And so in a case like this example, for as an example, using the right axillary to get to the aortic valve will be relatively challenging because this is an innominate artery that comes in high on the transverse arch, and there will be a great deal of retroflexion to get to the aorta. That's something you might not see if you're simply doing an ultrasound of the shoulder. Now, an ultrasound of the shoulder is great. It's certainly better than nothing. It will provide you information about the two-dimensional diameter of the vessel. It will provide you information about the calcification of the vessel, but it just doesn't obviously tell you as much more as you move more centrally into the body. An angiogram is probably the most common method of pre-screening an artery, an axillary artery, and it will tell you some information about how that artery ultimately connects to the aorta. The only challenge with relying on pre-screening with a angiogram up front is that the room setup between right and left axillary arteries is relatively different. And so if you have already set up the room to work on the patient right in standard fashion, and you take a picture of the right axillary and are sort of unhappy with it, or it's too calcified, or the relationship is not good, switching the room over to move to the left is a bit cumbersome. So having some information before you decide the laterality of your access is actually quite nice to do whenever possible. Of course, as you get more familiar with axillary access, perhaps you do a little bit more on the fly. Maybe you don't do as much screening, but certainly in the beginning, where you're kind of relying more heavily on external resources or even a proctor, these are important bits of information to consider. And so this does lead into room setup. It's really only germane to left-sided access. And as Dr. Tayal knows, because he does a lot of proctoring in this, as I have also done, right-sided access is very familiar. You stand on the patient's right, you just kind of move a little bit up the body. If you're working at the wrist already, it's not kind of a far cry to start working at the shoulder, particularly as catheters can kind of come down the body a little bit. You can almost, depending on the size and length of the catheters, you can almost work in sort of a similar position as you might normally. However, from left-sided access, it can become quite cumbersome. And one of the biggest modes of failure in these settings is where you put your fluoroscopic screens. The natural tendency of staff in a room is to take the screens, which would normally sit on the patient left, where you will intend to stand, and they'll move those screens towards the feet. That really creates a lot of difficulty for an operator, because the screens are now kind of behind you while you want to be facing forward, and you end up with a lot of looking back. You kind of get torticollis by the end of a long case. What I think is a very workable situation instead is to take the screens that would normally rest here and move them towards the patient's left ear facing the feet. in that way, if you put a table here off the left, you can almost face directly into the screens in a very reasonable fashion. It's a little weird to be that close to the screens, but very, very workable. The ergonomics of that will make sense to you, and it will be a lot easier to get the job done. And this is an example of that in a TAVI case, where you can see the screens up here, the patient is obviously here, and the screens are just kind of facing us along this, behind this table right there. And that is a very functional way to do this from left-sided access. Okay, the access itself, as mentioned, laterality is a big part of this because it does require moving from one side of the table to the other. I don't know that there are any data to support the decision to go from the right or the left. We did, and Raj, Dr. Tayal was a big part of the ARMS registry, which we published. In that ARMS registry, it was almost 50-50 divide as 100 patients who got percutaneous axillary impella implantation. It was almost a 50-50 split between right and left sided access, and the primary reason for that was simply a physician preference. There aren't any data to say that that right or left is better. I have historically felt that left may be better simply because most people are right-handed, and therefore if you had any complications, the ramifications of that complication might be less severe. That said, it's clearly easier from an operator standpoint to go from the right, and if when the rubber hits the road, if you have to do this very quickly, going from the right is probably a little bit faster. Okay, so in general, my preferred technique for doing this is to take an upfront angiogram. You can do this from the ipsilateral radial. I tend to prefer doing them from the femoral because that is antegrade flow, and so I think the pictures are somewhat better. It often leaves you the opportunity to have slightly bigger catheters for bailout strategies whenever necessary, but sometimes femoral access is simply not available. In any event, take a angiogram. I think we want to target somewhere along the lateral border of the rib cage, which is preferred in my estimation, because that is how you can offer manual compression as a closure strategy in these scenarios, and I'll show you a little bit more about that in a second. Then I like to put an 018 wire down the arm and leave it there for the duration of the case. That is simply a bailout strategy in my estimation. I put that 018 wire down the arm, and then I put a metallic instrument on the chest, and I fluoro that just to give you some sense sort of positionally of where to be. I've actually started doing this a little bit in a more sort of sophisticated manner, where I take the tip of the metallic instrument and I put it right at the lateral edge of the rib cage, and I draw a line along the metallic instrument and then cross it with the T to tell me where the rib cage roughly is, and that just helps me sort of guide needle access a little bit more. And it's for this reason. One thing about percutaneous, I fluoroed my hands just for you. This is from 2014 or something like that. We do this under ultrasound, which is portrayed in this fluoroscopic image. One point to note is the needle angle. Most operators who are right-handed and are used to sticking femoral access will sort of stick down almost like throwing a dart, because that is sort of the orientation of the femoral artery. When it comes to sticking the axillary artery, the artery actually runs sort of towards the move with the needle is actually more like pushing a pool cue. If in billiards, if that, which this can be difficult for folks, is just that if you are sticking kind of downwards, A, the wire coming out of the needle is going in the wrong direction, and B, you've reduced the surface area that you have functionally to target or access the vessel if you're going in a non-parallel trajectory to the vessel. On excuse me, on ultrasound, you can visualize that 018 wire within the vessel, which is just a further kind of discriminator that might help you understand what you're looking at, particularly if someone has bad tricuspid regurgitation and the vein is also somewhat pulsatile. All right, let's, oops, sorry. So last, but certainly not least, is closure. So access is fairly familiar to everyone. Closure does deserve a little bit of attention in this last minute or so. Because you, at least in my cases, because we have the 018 wire already up in place, whether from the wrist or the leg, that allows you the opportunity to do dry field closure, where you can deliver a balloon just proximal to the vessel and slowly inflate that. This is kind of a balloon sized roughly 1-to-1 to the proximal axillary or distal subclavian artery, and you just inflate that to 1 or 2 atmospheres. It allows you the opportunity to either do a very controlled manual compression or cinch down perc closes in a very controlled way. One of the arguments for doing this is that there have been, in the ARMS data, we saw about a 3% rate of brachial plexus complaints. They were all C8 nerve distribution, kind of distal, pinky and ring finger, tingling and numbness, but they all occurred late. And the hypothesis here, at least my hypothesis, is that this represents external compression of the brachial plexus from a little bit of contained hematoma. So being really precise with the closure is kind of nice, and a dry field with a balloon tamponade is one way to do that, and I'm sure that most all operators here are quite familiar with doing so. I will just show you this. This is also cadaveric work in a closed chest. There is an endoscope looking from the subclavian down to the axillary artery, and this is in a perfused cadaveric model, and this is me simply pushing on the chest, demonstrating that manual pressure is entirely feasible from the axillary artery. Of course, it does depend on where you stick, and because what you're relying on is that you are behind the second rib, and manual compression of behind the second rib, entirely feasible. We have explanted 14 French sheaths from the axillary artery using nothing but manual pressure and the girth of our fellows, or the strength, maybe I should say the strength of our fellows, because they weren't girthy, they were just very strong, and that has worked just fine. So a little bit on the ARMS data, I mentioned that briefly. This is available for review in Circulation Cardiovascular Interventions, published last year, with Dr. Tayal as the senior author, just showing some of our, it was a multi-center national registry of percutaneous axillary access, and so there are at least some brief data to guide what we might expect using this access point. And with that, I will wrap up. I think, in conclusion, axillary access is reproducible and can be performed safely. However, there are some specific considerations one must consider. Manual pressure, I do think, is a primary bailout strategy when necessary. Balloon tamponade is certainly very feasible. And then, of course, stent grafts if needed, but one must be familiar with that technology before applying. All right. Thank you very much for your time. I really appreciate the opportunity to be involved in this wonderful conference. Take it away, Dr. Tayal.
Thanks, Jamie. That was excellent as always. Really learned something new every single time I listened to you go through this. So thank you. And thank you for joining us so early this morning.
Of course.
Next, we'll move on to Adam, who's going to...
I was just going to, Raj, can I just ask a question, please?
Absolutely.
Sure, and thank you very much, Dr. McKay, for getting up so early, contributing to the meeting, and I'm sure this is going to be appreciated by a lot. Tell me, are we now in a time frame where cut downs on the axillary artery for access should be out? Should all of us be really fitting into it and saying all of us who need to go through the axillary for anything should actually be doing a percutaneous? Is that correct?
Well, I think someone of your talent might feel that way, and certainly there are certain centers where that has worked really well. I will note that all politics are local. Multidisciplinary doctors at various. It has been the case at our institution that we do not really perform any open axillary access at this juncture, and we also don't have a great working relationship with our vascular surgeons. That said, other institutions are very different. Perhaps their vascular surgeons work faster, work more collaboratively. I don't know that there are any data to inform the discussion, at least in a in a sort of a national way or in a international way. And there's nothing. We have published a few bits of data looking at hospital was shorter with percutaneous access, length of ICU time was shorter, length of fluoroscopy time was slightly longer, but there weren't any clinical outcome differences between the two. So I think it's feasible to do, but obviously it depends a lot on the skill sets of.
Thank you.
Jamie, can I ask a question? By the way, Anna says hi.
Hi.
Jamie and Raj, any tips and tricks if you modify the approaches you described for balloon pump versus an Impella?
Well, I'll just briefly mention that for percutaneous axillary balloon pumps, I've started tunneling them all. So which I find, I don't know that it is of great benefit, but I find it fun and I think it helps a little bit. So I get percutaneous axillary access, and then I get a secondary access pump site slightly distal to that, maybe 1 to 2 inches, 4 or 5 centimeters distal, and somewhat more lateral. And I will externalize the wire through that track and then deliver the balloon pump in a tunneled fashion, which I've just started doing for anyone where the balloon pump's going to stay in for more than a few days. And I think that may help with stability of balloon pumps from the axillary artery, because I will note that they can move around from the balloon pumps in particular seem to come backwards a little bit from an axillary approach, whereas Impellas, I think, from an axillary tend to be more stable. So,
good. Okay, Raj. So please continue.
Great. So next we'll move on to Adam Greenbaum, who is probably one of the world's leaders in pioneering transcable access for large bore arteriotomies.
Or if anybody's still on the line, and about femoral, and that situation when the bifurcation is really high, like you showed, Dwayne. But what if the SFA is, still 8 millimeters and looks healthy? Can you stick the SFA right where the femoral head is, where it would normal be? And does it behave completely normally? And is that acceptable? It always comes up. What do you guys take?
So my opinion is, first of all, this whole forbidden fruit of the SFA was because routinely accessing the SFA in a non-compressible site is where the complications are. So if the SFA is in a compressible site, it's where you want it, and it's of suitable size, I access the SFA.
So it's acceptable.
It is, yeah. But to your point, Adam, though, it is a different artery. Just like the behavior of the subclavian is different than the behavior of a coronary artery and the distal aorta, the SFA is a crappy artery. It is more friable, and it has more, friable disease. And then you have to make that angle with the wire regardless of where the bifurcation is. So that poses a little bit of a problem. But for access and closure, size and location and compressibility is what dominate for me, not the name of the artery.
But you could certainly be far enough away from the bifurcation sometimes and be right where you need to be. All right, can you guys see my slides okay? How am I doing?
Yeah, we can see.
All right, do I get credit for using the template? Come on, give me some credit.
Brilliant.
Okay. All right, trans cable access. Here are some disclosures. So this is more of a how-to, but the reason this came up, of course, is because of all the information on this slide, right? Which is regardless of what kind of support you want, it is big sheet size that you need for access, regardless of what you choose. And we all know about the vascular complications. So, so if you think about support, or at least this is what I think about hemodynamic support, which is what am I using it for? Am I using it for supported PCI? And in that case, you know, the magnitude of support, maybe not as much, and the duration of support maybe typically shorter. But if you're thinking about it for shock, it's a whole nother ballgame, right? Because you want to get it in quick. You want to get as much support as you can. It's probably going to be in for days. And so then you have to think about some of these things on the bottom, which is venous return, limb perfusion, blood loss, hemolysis. And of course, you know, could you make this as least invasive as possible should you need to escalate to more durable support? So what came up was, could alternative access for getting large bore sheets really help in terms of would people use it more, as opposed to saying, yeah, the vessel doesn't look good, maybe we'll just put in a balloon pump. Could you get longer, more significant support? And would this improve outcomes? Although it's not proven yet, that there is some hint of a signal that I think we do. And of course, these are the two, which would be the transcatheter approaches to large bore access. Of course, Jamie just told you everything you need to know about PERC-ACT, so I'll concentrate on the transcaval part. Now, what's a little different, or why might you want to think about transcaval as opposed to PERC-ACT? Look, the aorta is the largest vessel in the body, and you're going directly into it, and so you can get a 30 French sheath in percutaneously, and you can. It's a ship in a bottle. You can put whatever you want through a 30 French sheath in the aorta. The vessels are pretty much right next to each other, and technically you wouldn't have to worry about indwelling per-closed sutures if you wanted delayed closures. I mean, obviously there'd be a duct occluder at the end, but at least during those days of support, there wouldn't be any sutures if you worried about sterility. And the last thing I'll say is, for me, every month my radiation bed just seemed to light up more and more. And even for the time, even if you're going to switch to the leg for your coronary intervention, if you're up there just for that time getting axillary access, you're getting a little bit more radiation unless you really have good shielding. And if you look at the two schematics on transfemoral and transcable, they're identical. Okay, so two things we got to talk about. The first is, well, what if you're just doing supportive PCI? I think in these cases, doing a CT, just like Jamie emphasized, and getting your time and your landmarks and where you want to go, I think is the right way to do this. Unless you had a big creatinine problem, I think it's the way to go. And so then it becomes no different than transcaval access for TAVR, right? Which is you find a calcium-free window with nothing in between the two vessels that's at least 1.5 centimeters above the iliac bifurcation and below the lowest renal. Make sure you understand how big the vessels are for your bailout plan, et cetera, just like you would for TAVI. And then you can move on. So point is that transcable is the original OG of single access PCI, by the way. I know everyone talks about it with Impella, but in actuality, we showed back in 2015 for a TCT Live case that you could do everything you want through transcable. Here's a 5-liter Impella and 2.8 French access for any kind of retrograde work you want to do, all through single access. So this is the ultimate of single access PCI if you want to do it. So the setup, you need standard transfemoral setup. Just put a grounding pad on the patient's hip, for the Bovie application. Biplane's nice, it's not necessary. You're going to use the right femoral vein for the transcaval access, and you do need one other artery, typically whatever femoral artery is best. other axis you want for the PCI. You want to go single axis transcable, you can. If you want to go radial for your PCI, have at it. And keep in mind that protamine does help at the end. And so you just want to, but pretty safe even in terms of CTO work, giving protamine at the end of the procedure. So what you do during the procedure, of course, is you code register your angiogram to the CT. You're looking for this calcium-free window that you identified on your CT scan. You're going to make yourself a wire that can electrify just to get across, and you're going to have a telescoping system to help get to an 035 wire eventually. We typically just clip to the back of an Astato 20-gram tip wire. We set our Bovie at 50, a pure cut, and that seems to view. You will it'll look like a bullseye, and in your front view, in your front view, it'll look like a bullseye, and in your side view, you'll be headed towards it. You will electrify the wire just for 1 second and push through to the aorta if you're not careful. You grab it with the snare just to secure the wire, and you'll send your wire and snare combination up into the thoracic descending aorta just to make a rail. And then you'll send this telescoping system across. It's any 014 microcatheter. It can be a piggyback. It can be a fine cross, sort of a 130 fine cross. And then once that's across, you can send any 90 centimeter 035 microcatheter like a Navicross. There are many others. And then you take out the wire and swap to your Lunderquist. And now you have a stiff wire to do your job. And I will keep in mind, though, that if you're just putting in an Impella CP for supported PCI and you only need a 14 French sheath, you do need to take a dilator and go across the transcable tract and back, because the 14 French sheath is not stiff enough. It's not a TAVR sheath to get across on its own, even over a Lunderquist. So we routinely would just dilate with a 14 French dilator just to make the tract bigger. And keep in mind that this also does test the hemodynamics, so everybody's not nervous, because when you pull that dilator back out, you won't see any change in blood pressure. And even if you did have a drop in blood pressure, then I guess it would at least tell you that you might have to move a little bit quicker for the closure at the end. So here's the case, though. So what about about, well, can you just do it on the fly? So if you bring the gantry to 90 degrees left lateral, they're separated, you rotate the gantry back towards LAO until the vessels line up, until the two pigtails line up. So that's how you just found your side view, or I should say your en face view, your bullseye view. And if you just take that and now move 90 degrees from there, that is your side view. So let's say it took 60 degrees of LAO to line up the two catheters. Now you know it's 30 degrees of REO, which is where you're going to burn. You're going to look at the pigtail at 60 degrees of LAO. Okay? If you went to left lateral and the two pigtails, the two vessels were directly lined up on each other, you know it's just AP and lateral. So burn AP. And the last situation is, what do you do if you start left lateral and you rotate back towards AP and the vessels, instead of coming together, they spread apart? So that tells you that you're in this situation where the IVC is more anterior. So what you do in that case is you move the camera the exact opposite to 90 degrees right lateral. They'll again be separated. Now you pan back until the vessels are superimposed, and there's your side view. I should say, I'm sorry, there is your en face view. And then, of course, 90 degrees from that is where you would burn. Does that make sense? So you can do this on the fly in 5 minutes. 2 pigtails in the 2 vessels. Understand, because the ultimate situation is you just need to know what you're looking at when the 2 vessels are superimposed on each other and when they are farther apart. So what did we do in this person? We started to pan back and we noticed that the 2 vessels were, or the 2 catheters were separating. So we swapped to that REO. This is the least common situation. We panned up, we found our angles, and we went ahead and burned towards the snare. You know, when some of these young people with shock from MI, they don't have a ton of calcium in their arteries, but the reason you're in that side view and you define that side view is that's when you fluoro to find no calcium on that wall. That's the only wall you care about, which is where there's no calcium. So here we are burning into the snare. That would be the front view, burning into the snare. And here we are then putting in a 22 French dry seal flex, and then through that 5-liter Impella. We've done many CTs on these patients weeks after these have been in, and there's no blood that accumulates in the RP space. The sheath is hemostatic. These patients are typically, flat on their back, but we don't typically find bleeding. So in those situations, delayed closure is now the issue, right? Which is, patients either recover, they've gone on to more durable LV support, or they've fixed surgically. You can leave all this equipment in until that time comes when you want to get it out. You can bring the patient back, and then sort of in a semi-sterile manner, right? You can drape the patient, and you can certainly leave the dry seal sheath in, or whatever 22 French, 24 French sheath you have, and of course remove the Impella. They can still be heparinized at this point, right? So once you've taken out the Impella and now you have the sheath in, okay, now it's time to then go on and close the patient. So now you can more sterilely prep the patient, get ready for your closure, and then go ahead and do standard transcable closure techniques that you can read about. There's multiple resources. The only thing we recommend is when a large sheath's been in for days to weeks, there's less recoil of the aortic wall. So we recommend the largest first generation duct occluder. That's the Amplatz 1210 duct occluder. The only tip that I'll say is that no matter what, even if you've given heparin, there's always clot that forms in the sheath. And when you push your stuff through it, we don't want to send that into the SMA, into the renals, down the legs. So we typically take like an 18 cook inside it, and we aspirate, and then we will remove any clot until it's all clean, and then we'll go ahead and close. So again, use heparin through the sheath for prolonged transcaval access, and then try and declot it. Many times it's not in there, but I show this as an example of what to do just to make sure that there's no clot in the sheath. And then lastly, I'll just mention, here's another 72-year-old who came for elective transcaval TAVR for a bicuspid AS. We put a 26S3 that happened to be up 14% oversized. And of course, our picture immediately after shows annular rupture in the right sinus. So we quickly drained the blood with pericardiocentesis, and of course, bleeding was ongoing. And the decision was made in this low-risk patient, of course, to convert to surgical correction. So we had transcaval access. So all we did was swap out to a 2465 dry seal and put the bypass cannula right in the back of it. The reason I chose the 24 was to have a little bit of room, because some of the end hole of the outflow cannula will not necessarily reach past the end of the dry seal flex. I chose a 65 so I could put the end hole up in the aorta, where it's up in the thoracic aorta, where it's nice and big. And then we drove the 24 French inflow cannula from the left femoral vein right past it. And so this is, full cardiopulmonary peripheral bypass through a transcaval sheath, fixed the vessel, and then closed. So if you look at all the access methods for LV support, here they are listed, and there's good and fair and what I would think are not optimal. for all of them. And I think between the two novel ones that we've now just discussed is, I think you can get a bigger magnitude of support. I mean, obviously there's the 5.5 liter short Impella now, but still takes a 20 French sheath. So I think you can get more magnitude from a transcable axis, but at the cost of mobility if it's going to be in for a long time. So here's the summary for transcable axis and sort of novel approaches. Is I think getting this done quickly. You can do this in the middle of the night on your cath lab table, calling in no extra support whatsoever. You can do this with your cath lab team, and I do believe that getting more support quicker is better, getting them off their drugs, and I think we can prove that outcomes will be better if we can get more support. Thanks.
Excellent. Thank you so much, Adam. That was great. It was very, very helpful and very, very practical.
Did the animation make sense, or is it too complicated?
Animations are great, Adam. Really, really clear.
Loved it.
Beautiful.
So I have a, I want a clarification. You said take the dry seal sheath out, clean it. I guess you balloon tamponading the aorta at that time when you take the sheath out, clean it, and then put it back in. Is that what you're doing?
No. So what I do is I take, let's just say there's a 33 centimeter, 22 French, dry seal in. I'll just take sort of semi-sterilely, I'll take an 18 French Cook. That's only 30, right? So I know if I drive it all the way in, it's not going to get out the end. And I'll just push it in the back and I'll start to aspirate. And then when it gets clotted off, I'll pull it out and dump it and keep doing it. And all I'm doing is cleaning any clot out of the sheath. And then I re-drape the patient, re-sterilize, and then go ahead and close.
Got it.
Because the first 1 or 2 times we did this, we saw some clot in the SMA and stuff, and we figured that it was just that it wasn't there. It's just that we extruded it out when we pushed our closing devices.
And the second aspect is how often have you had to use a covered stent in the aorta to close off the connection, which you couldn't otherwise?
It's down to about less than 1% of cases needs a covered stent.
Mm-hmm.
In fact, with early administration of protamine, and I think smaller sheaths for Tavia, of course, more and more, even with off-the-shelf, non-dedicated product, the what we call type 0 closures, or beautiful closures at the end, are more and more common. You're not going to get that with this situation where it's been in for 2 weeks, because there's just no recoil of the wall of the aorta. That shunt, on the other hand, is just not going to be a problem for these people that closes within a few days.
Mm-hmm.
How many times we need to close the aortocaval fistula with a duct occluder device or something?
We universally use a duct occluder. That's what we use to close it. There's nobody who's intentionally had their tracts left open.
Yep.
Is that what you're asking? Did anybody just pull it and leave it?
Yeah, so to be tamponade, we have to anyways put a device every time, no balloon tamponading or.
So for balloon tamponade, by the way, I do not think you need to do that every time. It's not a dry closure, by the way. We don't put a balloon to stop flow while we close it. We just close, because once you pull the sheath back, that fistula, the decompression of the lowest point will be in the IVC, and the blood will flow from the aorta to the IVC. So I would say
and anticoagulation has to be.
So everybody will get protamine at the end of the case at the time of closure. And
anticoagulation, the low pressure system in the IVC.
So anticoagulation afterwards? Is that what you're asking?
Yeah.
So once whatever anticoagulation the patient needs.
Pressure.
Sorry, I couldn't hear you.
I think she's asking about anticoagulation, and I think you answered that saying that you just reverse anticoagulation and give protamine at the end.
And then whatever they need post aspirin, Plavix,
correct,
oral anticoagulant, they're all okay.
Right.
Sure. I think we should just one last question. So you and your team are very good at it. You have refined the technique and you refined every aspect of your team accordingly, is that a default access site as far as you're concerned, for apart from femorals, obviously?
Yeah, that is our preferred access for, let's say, first alternative access that we look to. That is our default for a high level of support. It's our default for some obese patients, even if they have big enough vessels, because the larger hole technically at the groin is in the vein. You know, when I really look back on things, I'd actually rather deal with bleeding in the abdomen than bleeding at the common femoral. There are actually more devices and more, first of all, you can see it more easily. The camera is in the abdomen. It's, you know, and in terms of covered stents and things, you know, there's always that question. Dwayne showed that case, you know, the surgeon said, sure, go ahead and put the covered stent in, but technically you have more in your armamentarium to deal with things in the abdomen. It's a large vessel. It doesn't move. It doesn't bend. So.
Okay, Raj, we could move on. Oh, so I've got to invite Raj. So Raj, over to you. Advanced closure techniques, complication management, tough calls, great saves.
Great. So it's a pleasure to be here. I'm just going to review some complications and some closure techniques that we've been using in our practice pretty routinely. This is one of my favorite quotes by Mike Tyson. Everyone has a plan until they get punched in the mouth. I think it's very applicable to any form of large bore access or access in general. You need to have bailout strategies and figure out how to get yourself out of messes, even when they're not intended. So complications, I like to divide them into access versus closure related. With regards to access, it can relate to the site of access, the angle of access, the technique that was used to obtain access. With closure, it can be device related, obviously, anatomically associated. And then I think it's important to have some bailout strategies in your head ahead of time, regardless of the size. Dwayne had reviewed this. I think it's important to have some understanding and appreciation of conventional versus functional zone of access for the femoral artery. Again, it's important to be underneath the inferior loop of the inferior epigastric artery and above the bifurcation, but also above a compressible landmark in the event that bleeding occurs. I think we're all very, very familiar with the complications associated with either being too low and having the development of risks of pseudoaneurysms, as well as obviously being too high, which is a much larger concern clinically as well as hemodynamically, with concerns for the development of retroperitoneal hemorrhages. So access site, Jamie talked about brilliantly in his talk about percutaneous axillary access. I think it's important to know anatomic bony landmarks, both in the femoral as well as axillary space, being familiar with landmarks such as the ribs, the clavicle, as well as the head of the glenoid, as well as the glenoid cavity, and kind of defining the steltopectoral triangle. It's also important to understand that the relationship of the artery changes with the relationship of the brachial plexus depending on where you are in the artery. So things that have happened is people have either gotten access too proximally, which puts them in an intrathoracic space. That increases the risk of development of pneumo or hemothoraces. And then traditionally, when people first started doing axillary access, it was fraught with a very high percentage of neurovascular complications. And that's thought to relate to the fact that most people were obtaining access in the third portion of the axillary artery, where there is this neurovascular bundle encompassed within fascia. So any extravasation in that area will obviously lead to a higher rate of brachial plexus injuries and compression. So we also talked a little bit earlier about the angle of access. In the femoral artery, the ideal access angle is approximately 45 degrees. However, in the axillary artery, we want to be a little bit more shallow and try to tend to lean more towards 25 degrees or as shallow as allowable to get to where you need to go. So in a lot of instances, I've seen a lot of these different cases, and I'm sorry, the image on the left is a little hard to discern. What you see is that there is a 6 French sheath that's been introduced at a very steep angle in relation to the axillary artery, and there's a very significant kink in this vessel in the sheath as well. So what ends up happening is if you do decide to upsize that over a stiff wire or whatever have you, there is a strong preponderance to have late bleeding and actually bleeding while you're doing all your catheter exchanges. It also leads to a higher tendency to have kinks in the sheath, which can then lead to having a very large sheath in place without being able to deliver your Impella, your TAVR device, or what have you. So it's very important to be cognizant of these things as you walk through these steps in your algorithm. Conversely, what can also happen is when your angle is too steep, you can also lead to a splaying of the vessel. Here you can see we have our bailout wire as Jamie described. It's an 018 wire that's being advanced in an antegrade fashion from the common femoral artery. And this is our retrograde 035 wire that was initially placed through the large bore sheath. Our dry field balloon closure device is right here, just an 8x40 balloon. However, you can see what's happened is the angle has led to this large perforation in the vessel, which translates, despite using manual compression and the use of a covered stent, to a very large hematoma, which you can see over on the right, and a relatively unhappy patient who was successfully discharged without too many issues afterwards, a couple units of blood and a covered stent. That said, it's also important to understand your limitations of covered stents, how to deploy them. This is a flexion point in the axillary artery, so you should use theoretically a self-expanding stent. You need to understand the sizes required to deliver the sizes. Typically, you want to oversize your covered stents by 1 millimeter in regards to the target vessel. So with regards to technique and access, I think a lot of times people underappreciate the tactile feel and component of access. A lot of us, ultrasound has now become the norm, but before that, a lot of people used manual palpation. It's very important to feel the wire, especially when you make a transition to a micropuncture wire and needle. A lot of times people are not totally cognizant of that, and you can kind of go below the vessel and then re-enter it almost like you would in a CTO. And that can relate to the development of retrograde dissections, typically which are benign until you get to the point of closure, where if you deployed a closure device and you are kind of subintimal, so to speak, or in the posterior wall of the vessel, it can lead to acute vessel closure. So kind of being cognizant of that, taking your time and using multiple modalities like Dwayne speak to for getting access is really a good practice. Again, it's also important to watch the wires as you advance them, particularly the micropuncture needle. There is still the risk of developing a retroperitoneal hemorrhage if you push this wire too far up into the circumflex vessel. This can be felt tactily with your fingers. However, until you've developed that, it's important. I always get the fellows to kind of visualize the wire traveling north until that. Similarly, in the axillary artery, here you can see the wire has gone in the wrong direction. It can be a little dangerous at points and a little disconcerting to see. So I do recommend just watching it for the first couple of times. Now, with regards to closure, it's also important not only to assess under ultrasound where your target is, but also proximal and distal. So here, this was a TAVR case where the operator successfully avoided this ball of calcium by obtaining access just distal to it. However, failed to recognize that there was a subtotal occlusion in the superficial femoral artery just distal, and this vessel was still relatively calcified throughout. So what ends up happening is after they deployed their perclose, the patient went up to the floor uneventfully. As Dwayne had pointed out, there wasn't a lot of bleed back after they deployed the percloses, but they didn't evaluate it fully. So the patient comes back to the lab with a cold, painful foot, and you can see now from where there was a little kink from the perclose, there's actually very minimal flow to the leg. So this required access from the left radial artery and then balloon using one of these radial to peripheral profiles to restore flow into the SFA and kind of balloon where the perclose had cinched the vessel down too much. So it's important to understand your surroundings, so to speak, both proximally and distally to where your point of access is. So I think a lot of times what we see both in morbidly obese patients as well as in the axillary artery, it's a little bit different because you're not traveling through as much subcutaneous tissue. In the axillary, you're actually, in most instances, traveling directly through pectoralis minor. So there's a tendency for the percloses to get snagged on some of that tissue, and that relates to having kind of incomplete closure. So this you can see is a little extravasation with a balloon that's been advanced to this area after perclose deployment and final angiography. So all we do here is advance this balloon that was used for dry field closure, and then you can see my hands applying manual pressure on top of that This is held in conjunction for 5 minutes without protamine. Usually we'll do that for 3 cycles. And then repeat angiography shows in most instances, this will completely resolve any form of bleeding, not only in the axillary artery, but also it works very, very well in the femoral space. One of the things that we've published before this image is courtesy my friend Amir, who you guys heard from yesterday. So the axillary is compressible, as Jamie also brilliantly described and demonstrated on that cadaveric model. We routinely pull our intra-aortic balloon pumps manually, using only manual hemostasis on the floors. I know that people get concerned with regards to the presence of bony landmarks. Jamie described using the rib. You can still compress it as demonstrated here, even out towards the second portion of the vessel. It's important to kind of be familiar with imaging. So not just the straight AP view will always show bleeding. It's important to either take a little cranial or caudal view to appreciate that. Digital subtraction angiography is preferred. And again, this kind of cadence where you have the dry filled balloon that's used for dry closure, which is sized 1-to-1 with the artery. It's a low pressure inflation. We'll inflate it right to the site of extravasation for 5 minutes and then apply manual pressure. It's important that you apply external pressure as well. And then do a 5-minute prolonged inflation. Do that twice. If they're still bleeding, then we'll administer some protamine and hold it up for another 5 minutes. And I think we've used 2 covered stents in our entire experience. I think something else that's very, very helpful to be familiar with is another technique we call hybrid closure. We published this technique. Here you can see we have a 14 French gore sheath that's been in place. There's an 035 wire going through it with 1 pre-deployed perclose in place. The sheath is removed and that pre-closed perclose is deployed on the 035 wire, after which a 6 French sheath is reinserted into the arteriotomy. We then pull the wire and we'll do an angiogram and also assess for external bleeding. If there's not a lot of external bleeding, you then have the choice of using a MINX, which I would really never recommend, an Angioseal or another perclose device. If there is bleeding, then we typically upsize it and we'll either go with a larger Angioseal or another perclose. Just kind of anecdotally, we do see very, very good success rates with a combination of the suture-mediated and a collagen-based plug. I know some people are very, very averse to using angioseals, but it does tend to work very, very well, particularly in the axillary space. One of the important things that I would like to highlight for everyone is the importance of using that crossover balloon occlusion technique. So there's been multiple papers that have been published looking at this. Yesterday, Dr. Kirtani had showed us that the overall rates of vascular complications for large bore access approximate 17%, whether you're looking at PVADs, EVARs, TAVRs across the United States, which is extremely high. When you're looking at this paper that was published in 2016, specific to transcatheter valve replacement, the overall rates of major bleeding were around 14%, which has come down since then as devices have gotten smaller and more efficient. But if you look at the routine use and implementation of a crossover balloon occlusion technique, that reduces the rates of bleeding to 5.5%. So it's a very dramatic decrease. It gives you control, it gives you comfort, and it also gives you final completion angiography. This is a case where we, or the operator, actually opted to use IVL to facilitate delivery of a transcatheter valve system. However, they got access in the common femoral, which was calcified, and opted to only treat the iliac. So they neglected treating the common femoral. As expected, when you remove that, there was a large perforation. However, this was saved again by that combination of using internal balloon tamponade as well as external pressure. This took about 20 minutes to resolve. There was significant blood loss associated with it. However, we were able to get out of the situation without the use of a covered stent. I think it's important to emphasize that while IVL is a very, very good technology, you also need to appreciate and analyze the common femoral very, very thoroughly prior to proceeding with large bore access. To that point, we'll talk a little bit about single access, which I know Sanjog and some other people have reviewed in detail during this course. It's one of these things that has really, really taken off and been a very large game changer with regards to hemodynamic support and large bore access. I think it's interesting to see how viral this became based on a social media tweet prior to the development and publication in a peer-reviewed journal. But one of the downfalls of it is the fact that after you've deployed your closure devices and removed the devices, imaging becomes somewhat limited. You can routinely do ultrasound. It depends on your level of facility with ultrasound. This was another tweet that I've edited a little bit and taken the operator's name out. But basically what happened was the patient had a single access high risk PCI, and then eventually had to come back to the cath lab because they were hypotensive afterwards. The operator here came from a radial approach and recognized a bleeding. However, it's obviously too late by that point if the patient's already hemodynamically unstable. So one of the things that we've done to facilitate that and kind of remedy that solution is the use of an ipsilateral dry balloon occlusion technique. This will be published in JIC shortly. So basically what we do is just inflate an 8x40 balloon proximal to our large bore sheath. We inflate the balloon and then pull the Impella sheath out over the balloon catheter and then deploy our single perclose over it, re-advance the 6 French sheath, do a completion angiogram at the end of it. And this is similar to what I had shown during my case yesterday. Again, this is walk down with the reinsertion of a 6 French sheath. Here, the patient was a severe vasculopath. So again, I opted to use a mixed vascular closure device, which is extra vascular, and only for that reason that we use that in this instance. So some of the caveats and considerations that I just want to review briefly relate to large bore access. So one of the things that's kind of been teased out from the data is when you look at transaxillary access, whether that be surgical or percutaneous, there is significantly elevated risk of strokes. If you look at this data taken from TVT, you'll see that compared to transfemoral or transapical, the rates of stroke are kind of extremely elevated in transaxillary access. That is discordant, as Jamie points out, with regards to mortality. So there is something else that needs to be sussed out there. It's very unique and probably a little ill-defined, but it's something that you need to reconcile in your algorithm and considerations of alternative access. As Adam had mentioned, some of the additional equipment and a little bit of the learning curve associated with transcaval access becomes one of its limitations with regards to widespread adoption. And although IVL is an attractive option, you really, again, as I demonstrated, have to assess the common femoral and treat the common femoral either with a contralateral approach or prior to proceeding with large bore access. One of the things that we did more recently was, in this case, this was a patient that was brought for transcatheter valve replacement. And I know this is more of a CHIP CTO meeting, but I'm just talking with regards to all large bore access. This patient was a little more complicated. They had diffuse calcific disease. They were end-stage renal disease, extremely sick. EF was only 20%. They had diffuse calcification all through the aorta, kind of limiting any form of cable approach. There was a previously placed stent that was grossly undersized in the iliac vessel that protruded out into the aorta. So really limiting an up and over approach in a lot of aspects. And then you can see there was just diffuse calcific disease all through the iliacs and common femorals bilaterally. Similarly, the subclavians and axillary arteries were not ideal. There was a lot of tortuosity, as well as significant degrees of osteocalcification in the subclavian. So what we opted to do was just go ahead with routine percutaneous access. We published papers using the axillary artery for endovascular intervention. In over 60 cases, we had no stroke rates, and really vascular complication rates were on par with what you would expect for peripheral interventions in the femoral space. So we just insert a 7 French sheath here, which we've demonstrated is very, very readily. You can achieve hemostasis with just manual compression under ultrasound. We take our angiogram after we get access, and then went ahead and just used the JR4, put an 035 wire down, and then switch that out for an 014 wire, and then performed lithotripsy basically after doing an angiogram of the entire common femoral artery. I'll skip through a lot of these. Treated up into the iliac and sequentially used all 300 pulses and cycles and got the ostium of the aortoiliac vessel as well. And then went ahead with routine transfemoral access after doing lithotripsy of the common femoral. Took our time and used the dilator. You can see it advancing there without too much difficulty prior to advancing the large 14 French sheath throughout, without any issues really. And then from there, it's just routine transcatheter valve replacement with our valve deployment. And then, of course, using our dry balloon occlusion technique, we then have our wire in place, re-advanced an 8x40 balloon, had that inflated to low pressures, deployed our percloses. You can see a little bit of a perclose kink there, but we've seen that in most instances those resolved with time, and the patient did well and went home the next day. The last little bit that I want to talk about, just we're running short on time, is kind of occlusive sheath management. I think this is an issue that's very, very real. I think people have had a lot of issues with bleeding after removal of this peel away sheath. It's important to recognize that there is a very large gap in the sheath in the catheter after the Impella has been placed. It is very prone to development of thrombus. It's not intended to be left in place and can obviously portend to very, very poor outcomes. As we've been shown in data, any form of limb ischemia related to MCS obviously increases the rates of mortality. So distal limb perfusion techniques have been very, very well described by Adam and others in the past. There's a combination or myriad of techniques that you can use, whether it be ipsilateral perfusion, which is through the side port of the Impella CP sheath. And then you have kind of antegrade access in the SFA. A contralateral technique, again, is something that's also very easy to do using a male-to-male connector as demonstrated here. This is something else that was recently published that I think is helpful to keep in mind, where the radial artery is used to facilitate kind of distal limb perfusion. It's called lend-a-hand. It was in CCI just recently. But one of the problems and limitations is for a lot of operators that are not endovascular savvy or comfortable, all these techniques still require antegrade femoral access, which can be challenging in the setting of having patients having large abdominal pannuses or just having tortuosity where the wire gets redirected into the profunda. So one of the greatest ways I think to get antegrade access is taking traditional retrograde femoral access using an OmniFlush catheter or any one of these curved catheters, advancing your wire and then having it come back down antegrade from the iliac down into the femoral, and then you can simply reverse your placement of the sheath. So I think it's something just to keep in your wheelhouse in case the event that you need to use this to bail yourself out. With regards to the repositioning sheath, I think there are a couple of tips that I'd just like to leave everybody with. It's much more ideal if you can take the peel away sheath out early, because as Adam even pointed out, too, vessels tend to recoil better the sooner things are taken out. If you've done a 5.5 hour, complex PCI CTO, the chances of that vessel recoiling around your your repositioning sheath are much smaller. So our standard cadence is really to deploy one perclose up front no matter what, have that placed at 12 o'clock, and then just keep that in place. So if there is a little extravasation after you've taken your peel away sheath out, you can simply pull on the non-locking suture to bring the arteriotomy closer to your catheter and reduce any bleeding. It gives you a mechanism of control while you're in the ICU. You can also then move on to hybrid closure or deployment of a late closure device via the SAG port as available. There has been publications looking at the safety and efficacy of using late deployment of pre-closed perclosed devices with 0 rates of infection. We do recommend keeping them sterilely prepped, and that does not mandate the use of antibiotic therapy. This is the last little tip and trick I'll leave you guys with. It's something we use routinely for both MCS as well as ECMO cannulas. It works wonderfully. So this is where you have no pre-closure device in place. You remove an Impella sheath and then basically put 2 035 wires through the side port, and you're upsizing the arteriotomy then to 2 8 French sheaths. Those are placed side by side like an owl's eye, and then you sequentially deploy a perclose on 1 8 French and then a perclose on the second 8 French. So you're walking yourself down after making that arteriotomy a little bit larger. Obviously, this can be applicable to balloon pumps where you use a smaller wire. Most are compatible with 018 or 025 wires. For ECMO cannulas, you can use slightly larger sheaths as needed, but it works very, very well. We've had great success doing this. Thank you.
So Raj, that is tremendous. Really enjoyed it. So many questions in my mind, but I can always ask you those offline, just in the interest of time. We are at the moment 20 minutes overtime, so So Raj, I think we will end this session unless anyone has any burning questions, and then you can be shot for an answer. Does anybody have any questions?
Raj, what about the myocardial contrast? Definitely after having this kind of closure to see a slow persistent leak. Is there any role for myocardial contrast agent to see under echo or ultrasound?
Sure. We'll usually just use color Doppler, but if those things are available, that's certainly a good technique to use as well.
I just have a quick comment. I know that none of us like to hear that our babies are ugly. So when someone talks trash about Transcable, Adam takes offense. Someone talks trash about Axillary, Jamie and Raj will. But when it comes to single access, the idea that you can't do an angiogram, I mean, you showed the hybrid closure. So what I do is I use the pre-closed place sutures, take out and tie down onto the micropuncture sheath that I already have from when I got access and take a picture. So I don't know that that's really a valid, issue. I think the case that you showed was the problem was that the angiogram wasn't done, not that the single access was not correct.
Just one last question. Raj, did I understand that you, for the impeller sheets, you just gone on to a single pre-close, or was that a single post-close? Or are you still two pre-closes?
So
I didn't quite get a hang of that.
You can do both. Theoretically, even for 23, 26 millimeter transcatheter valves, one per close is usually sufficient, assuming that you have good positioning of it. Even for post-closure, when you rewire the side port, a lot of times that catheter is 9 French. When the housing comes out, it expands it a little bit. But even one per close is usually good enough. If there's a little bleeding, then we'll put another one in. But certainly one is usually pretty adequate.
Okay. We're going to move on to now the last session, which is my worst nightmares. And we're coming to the end of the day in India. And I think it's the right time to discuss nightmares so that we can sleep well at night. And I'd like Kathleen and Dr. Kirti Punamia, Dr. Kathleen Kearney and Dr. Kirti Punamia to take over the chair of this session with Meerwat, Raj Teal, Dr. Hiramat, Milan Chagh, and Dr. Hazran Rupali Khanna as the discussants. Over to you, Dr. Kearney and Dr. Kirti Punamia. Thank you very much. Over to you.
Hey, thanks, Ashok. This looks like an exciting session. We have some of the stalwarts from all over. They're going to present their worst nightmare. It's the most sought after session, actually, and coming to the end before the curtains are drawn, I think this will be a showstopper, really. So without any ado, I want to invite Jonathan Hill to present his first case. Chug, Dr. Hazra, and Rupali Khanna. Welcome, Jonathan.
Hello, can you hear me?
Good.
Great. So thank you for asking me to present in this session. So the case I'm going to present is one that was the source of lots of arguments. This was a case that was eventually done during a live case meeting. And the course directors, we argued and argued about whether or not we should do this case. The situation was, it was a CTO meeting, a complete REVASC meeting, and we were dealing with a lot of cases which had been failed in other hospitals. And this particular case, there were multiple attempts at PCI for this patient, which had failed. The patient himself was an extremely tragic background. He was a diver on an oil rig and had been driving up in the Highlands of Scotland, having come back from one of the rigs. And he rolled his car and he broke his back. So he was paraplegic following a road traffic accident. He was in a wheelchair, and he would and he became progressively more limited, because as he was winding the wheelchair, he was getting very severe chest pain. He was a very heavy smoker, and he had developed really very severe coronary disease with an ischemic cardiomyopathy. Ventricle was in the range of sort of 20 to 30 ejection fraction. His predominant symptom was really very restricting angina, to the extent that he was no longer able to be mobile in his wheelchair. He'd been referred for surgery. This was in another part of the UK. And the surgeons had thought he was just too high risk for surgery and turned him down. He was then referred from this one major cardiothoracic center to a heart transplant for heart transplantation. And at that point, this was really when CTOs were getting going and the hybrid techniques were getting going. He was referred to one of the big CTO centers in Scotland, and he had his first attempt to open up his LAD, and it failed a hemodynamic collapse. And then another attempt a few weeks later with general anesthesia support, but again, the moment that you went anywhere near this gentleman's coronaries, he became hemodynamically unstable. Now, at this point, there wasn't really very much use of Impeller or high-risk PCI, certainly not within the context of CTOs, and I'd started doing some of these types of patients at my center. And so he was accepted into our live case course, and it was really with a lot of trepidation that we put this patient on the table. So we're looking at this high-risk CTO pathway. He's got poor left ventricular function. He's got 2 or more CTOs. He's got some degree of peripheral vascular disease. His lungs are not so good because of the smoking. And so we use this scoring system. This was one we've done. It's been subject to some multivariate analysis. And we're now in these types of patient with impaired LV function adverse anatomy and the additional patient factors are tending to use left ventricular support if available. So what we can see here is these are the Harrington rods in his spine. This is from his spinal injury, and we're putting the impeller in. And so in advance of going anywhere near his coronaries, we're putting an impeller in, and this is an impeller CP to keep him going during the procedure. Now, just to orientate you, for those of you who are CTO operators, you'll see that there is a right coronary occlusion just at the margin here. The right ventricular marginal is cross-filling the LAD, which you can see is occluded near its origin. So, and there is also an occlusion in the circumflex. The distal right coronary artery in this case is filled by the septals from the LAD, which is in turn fed by the right ventricular marginal branch. So complicated anatomy, and you can imagine that when you have two guide catheters in, which we have to use in this situation because we need to go retrograde, is that there is the risk, the moment that you engage the coronary arteries with any gear, that he's going to become hemodynamically compromised. We started off with the left anterior descending artery, CTO, antegrade wire escalation, which was successful. The right coronary artery was a bit more challenging, and so this was using retrograde techniques, quite difficult to join up. There's that marginal, which is cross-filling the LAD, but eventually the right coronary artery is opened up. So during this time, he does become dependent on the pump in situ, but not experiencing the nightmare of complete hemodynamic collapse during a CTO procedure. So certainly we'd made more progress than had been made before because of the hemodynamic support. Now we're then left with the situation with a retrograde wire in the right, the antegrade wire, which, so this is in the true lumen here. So very long diffuse LAD, ostial LAD, and there was significant left mainstem involvement. So we really wanted to give this chap the optimal chance. So we wanted to make sure that we were fully deploying all the stents and everything was done with imaging guidance. So this was a highly complex case in terms of the coronary anatomy and because of the hemodynamics. And we were really wanting to ensure an optimal long-term result. So we're using OCT. In this case, looking at the very long lesion within the LAD, we're sizing the left main, sizing the left main with OCT. So clearly we know what size stent we want there. We can go right down to the distal vessel, and we can work out where we want to be with our distal landing zone, and we can measure the external elastic lamina and choose our long lengths of stent. The distal LAD was optimized, therefore, using OCT. The left main is optimized using OCT. We're able to deal with the left main bifurcation, and certainly we've got good flow left main LAD. We didn't on this occasion do the circumflex, this upper marginal branch, but we felt that this was a reasonable result for the left-sided system, and really confirmed with optical coherence tomography, a very pleasing result with stent implantation. So this is a nightmare case from the outset, but we were able to apply the combination of our hemodynamic support, our hybrid CTO techniques, and sizing and optimization with OCT. So a 45-year-old male, multivessel disease, 3 CTOs, left main disease, poor LV function on LV support, with a successful CTO PCI to the LAD and RCA with left main stem stent placement. Thank you.
Awesome case, Jonathan. Any questions from my co-panelists or from any of the expert panels there?
Yeah, Jonathan is extremely challenging, difficult, but it was a wonder how he was surviving on 3 CTOs. And there are reports of REMA giving collaterals to RCA. There may be some unknown collaterals from other sources, which cannot be seen in routine angiography. Have you ever experienced any abnormal sources of collateral from other sources beyond the heart?
Yes, I don't think I presented it here, but the proximal artery, the proximal right coronary artery, often with the conus branch, there is I think it's the artery of Vuissens that goes across that can sometimes supply the proximal LAD, so can anastomose in the proximal segment of the LAD. I think in this case, this gentleman's case, he had one of those vessels. The right ventricular marginal collateral here really did fill the LAD very well. And there was very rapid filling from RV marginal to mid LAD and then the septal. So there was a very sort of direct route. The right filled, the proximal right filled the distal right through the RV marginal. So the very, very extensively developed collaterals. And he'd got to the point, however, though, he was getting grade 4 symptoms, even getting, he couldn't even turn the wheels on his wheelchair. He's now actually, and this is 4 years later, is now back to doing, his, he does a basketball thing with in his wheelchair now. So he does, sprint races in his wheelchair. So he's completely asymptomatic.
So, Jonathan, I have a question. I've seen you using OCT for these CTOs, and one of the big issues with OCT with CTOs is antegrade injections when you actually have the risk of having some false lumens. And so, is this your routine practice, or is this a one-off case? Or would IVUS have been equally good or even better, or something which is so extensive, the 2 CTOs?
I tend to use IVUS as the main imaging modality, certainly when with any kind of dissection re-entry. Ideally, I'd like to use OCT after stent implantation, but we've been using it fairly extensively in antegrade wire escalation, and certainly that's something that's been tested in the Illumian 4 study. There are a number of CTOs included in that study, so antegrade wire escalation should not be an exclusion for use of OCT.
Jonathan, that's a great case. I wonder if you could comment on, especially with this kind of complexity of anatomy and the collaterals filling, via each other, essentially, how you chose your order of operations and how you might adjust to that based off how the case is going, balancing support, so you have a little bit more wiggle room with the ischemic burden of the case, but, still an issue in this guy.
I mean, it's a great question, Kate. I mean, in this case, I think once the support was in place, the choice of order became less important than I think if there was no support in place. I think what caused the compromise with this gentleman in the first place, with the previous attempt, was having a supported guide in the right coronary artery, because that was the main collateral supply for both the distal LAD as well as the proximal, distal right as well as the LAD. So I think the logic for the way that we thought to approach this case was to do the LAD first. And so that was done relatively quickly and ballooned up before we got into the meat of the retrograde.
Is there a rule for percutaneous LVAD? I mean, in this, if he is a transport refusal, he has, Jolly can go for the HeartMate 3 or smaller pumps. Was there any consideration for LVAD?
Yes, there was, and I'm afraid just because of the very few organs available, there wasn't really the option for him to have a permanent implantable device at that time. And certainly, in the context of real, global ischemia, I mean, he had sort of true myocardial hibernation. Because of his circumstances, he was not considered a suitable candidate.
Case, I think we should move on to the next one. It's getting pretty late.
Right.
Thank you, Jonathan. And I'm going to invite Dr. Maccabi to get on with the second case presentation for this session.
Thank you very much. And show a complication. I have put this as one of my worst nightmares because